If your name was called, go to the registration table, get you a welcome box. And how about a round of applause for our winners? Ladies and gentlemen, please welcome Dr. Bethany Hughes.
Good afternoon, everyone. Thank you guys for being here on time. I know it's difficult to get back to the lecture after lunch, so we're glad you're here. It is my distinct privilege to introduce our next speaker, Dr. Barbara McDermott. I was lucky enough to train with her. She's one of my personal mentors, and a huge chunk of my expertise and knowledge in the field of forensics comes directly from her education and mentorship. And I feel exceptionally blessed to have had the opportunity to study under her tutelage. So Dr. Barbara McDermott, PhD, is a professor of clinical psychiatry at the University of California School of Medicine, Department of Psychiatry, Division of Psychiatry and the Law. There, she is the instructor of record for the UC Davis Forensic Psychiatry Research and Psychological Assessment Seminar. She received her PhD in clinical psychology from the University of Cincinnati in 1988. She has served as research director for the Department of State Hospitals for the past 5 years. From 2001 to 2016, she served as the research director at the State Hospital in Napa. Dr. McDermott has implemented numerous clinically applicable research studies, including evaluating individual factors associated with institutional aggression. She is also co-PI on a research project to evaluate the impact of institutional risk factors on violence, funded by the Harry Guggenheim Foundation. Dr. McDermott has an extensive background in consultation to state government systems on forensic mental health issues. She has published extensively in the areas of risk assessment and the assessment and identification of malingering, as well as other forensically relevant topics. And this is a specifically important topic for us here at the state hospital system as far as institutional aggression amongst our patients, both towards other patients and towards staff. Dr. McDermott has, over the past several decades, cultivated what's considered the largest body of research on forensic inpatient individuals, and she has helped shepherd many different projects that have impacted how we practice here at North Texas State Hospital and in the Texas State Hospital system. So it is my distinct honor and our privilege to hear from Dr. McDermott today. Thank you.
Hopefully to hear from me. Can you hear from me? Yes? Okay. And I made it over here without tripping, which I consider to be an amazing feat. So my plan was to wander into the crowd and try and keep this as interactive as possible. These blinding lights make partially difficult to come closer to you guys, but also I know with COVID and not wanting to wear a mask, I'll probably stay up on the stage and hopefully wander around on the stage to try and keep you engaged. I'm going to be talking about a lot of data today. I'm going to try and keep that interesting for everybody. I have been doing this for 2 decades now, and so I've had the pleasure of doing this for 2 decades, but what that means is that I have a lot of information, which Dr. Hughes asked me to come today to impart to you all because your system, it sounds like, is remarkably similar to our system. And so I'm going to be giving you a lot of information. I really encourage you to ask questions. This is designed to be useful to you all to help you understand your system by understanding California's system. So I try not to call on you, but I really do encourage a lot of questions. And I will try and keep the data as much as possible to a minimum, but it all sort of fits together. But let's just get started. So what first I should tell you is that I don't have any financial disclosures. I don't know if that's required here in Texas, but it is in California, so I wanted to let you know that. We're going to be talking about violence. I lifted this slide from Dr. Warburton, who had hoped to be here but couldn't. And these are headlines. The reason that I lifted this is because, as you'll see when I scroll through, violence at Texas state hospitals is also problematic. It's problematic across the country. It's definitely problematic in the state of California and the Department of State Hospitals. And that's why I'm here today, is to talk about some of this. So what I wanted to start with, and I don't know a lot about your system, so I wanted to start with a description of California's system. But first I should tell you what we're going to be talking about throughout the day or throughout the afternoon. I'm going to give you an overview of the Department of State Hospitals so that you can think about your system and compare it to what the Department of State Hospital system is like. Then I'm going to be giving you a very brief overview of some of the risk assessment tools, and I'm selecting the ones that we have used at DSH, at least that I used at the state hospital that I was at when conducting all of the research. And you've heard a great deal about one of them this morning from Dr. Shipley. I'm also going to then give you an overview of the research. I'm going to be talking a lot about how to translate that research into treatment and how to use the data to make really informed decisions. I've been very lucky in my 20 years in California that all of the administrations that I've worked with understood the value of using data to make decisions. And Dr. Warburton was going to talk extensively about that, and as a policymaker, how she used the data to make decisions. I'm going to talk about the data, and I'm going to give a little bit of information about how we use that across the system, and also specifically at Knapp State Hospital, which is the hospital that I was at. California is very large, as I'm sure everyone in Texas knows. You guys have a really large area-wide state. And I'm so sorry, I wanted to have a wireless so that I could talk with my hands the way that I usually do. The wireless isn't working, so I'm going to have to hold this. So when I fade in and out, just start waving your hands if you can't hear me. We have the most populous state in the country, and that comes with a lot of hardships and burdens, having so many people. One of the problems is that we have a lot of offenders in our system. I don't think this is true in Texas, although I'm eager to hear about your system in more detail. We do not have any voluntary patients in the Department of State Hospitals in California. In fact, the majority of the patients that we have at the Department of State Hospitals are forensic patients, meaning that they all have some kind of criminal arrest history. We have a very small number of people that are civilly committed, but they're long-term commitments. They're not the 3-day hold kind of commitments that some psychiatric hospitals have. And I don't know if that's true for Texas State Hospital system. You do have voluntary patients? Yeah? Yeah, I know Louisiana, which is the other system that I worked at, still has voluntary patients as well, but California does not. Nobody can walk into the state hospitals in California and say, I need to see a psychiatrist, I need treatment. That just doesn't happen with us anymore. We have ever increasing numbers of patients that are found not competent to stand trial. The Department of State Hospitals is the treatment facilities, there's several of them that provide this service, designated to restore individuals who are found not competent to stand trial as a result of a felony offense. The misdemeanor offenders go someplace else. Generally, they're restored in the community. We only, with very few exceptions, restore people for felony offenses. We have also a very large number of people that are found not guilty by reason of insanity. I don't actually know the specific numbers. I know at the one hospital that I was stationed at for the majority of my career There are about 1,200 patients, about 1,000 of them are forensic, and about 500 to 600 of them were not guilty by reason of insanity. So we have a massive system, and I'll show you a slide in a minute that compares it to the rest of the country. We have an interesting commitment type that I don't think most states have. It used to be called mentally disordered offenders. It's sort of the non-sexual equivalent of sexually violent predator law, only it's for people that have not committed sexual offenses, for regular offenses. It's now called offenders with mental disorder, and these are people that are found guilty for the offense that they were charged with. They're sent to prison. At the end of their determinate sentence, they are then found to be too dangerous to be released into the community because of their mental disorder, and their commitment is continued even though they would have gotten out of prison in the mental health system. So we now call them offenders with mental disorder. Pretty large number of those individuals. We are also the people that provide treatment for the sexually violent predators. And then there's other various kinds of small numbers of different kinds of commitments. We do not provide treatment to anybody under the age of 18. I understand that that's also not true in Texas. Used to have a program for adolescents. The state hospital system no longer has a program for teenagers. So we're talking about adults. On any given day, pre-COVID, things changed with COVID, but on any given day in California, the state hospital system holds about 6,000 patients. So we have a really, really large hospital system, and the majority of those patients are forensic patients. This is a graphic that I can't see, but hopefully you guys can. If I turned around, I'd probably be able to see it a little bit better. That just shows the increasing numbers of patients that we have in the state hospital system. The newest hospital that we have was opened in 2005. That was the hospital that provided treatment to our sexually violent predators and some other commitments as well. And so that was, gosh, it seems like yesterday, but that was, what, 15 years ago? Even still, our numbers keep increasing. Recently, the Department of State Hospitals asked to build another hospital, and we're told no because of the increasing numbers of incompetent to stand trial commitments, which I understand is also a problem in Texas. So we're limited right now, but the numbers keep increasing, and this is from a few years ago. It's gone up since this slide has been made. California's big, right? And we have 5 state hospitals in our system. We have the one that I worked at, which is at Napa, in the northern part of California. There's another one that you all have probably heard of, Atascadero State Hospital. It's the oldest purpose-built forensic hospital in California. It's a lot of people that are relatively well-known have been trained at Atascadero State Hospital because it's been open since I think 1954 and has served exclusively forensic patients during that entire time. But it was purpose-built. And by that I mean that it was built to be a forensic hospital. There are 3 hospitals in the state of California that were not purpose-built, that were built to provide treatment for just general psychiatric patients, and that's been a significant problem, which we can talk about at some point later in the presentation. Coalinga is in the Central Valley, and that's the one that was built and opened in 2005, again purpose-built to provide treatment to sexually violent predators. And then there's 2 in Southern California, one in what we call, and I have no idea why, the Inland Empire. Has anybody ever heard of the Inland Empire? I don't know where it got name, because it isn't an empire, that's for sure. But anyway, it's inland from Los Angeles, so it's by the mountains. I think its claim to fame is incredible smog in most of the summertime. And apparently beats Los Angeles, which is also Los Angeles' claim to fame. And then Metropolitan State Hospital, which as the name suggests, is in metropolitan Los Angeles. Because of the location of the Metropolitan State Hospital, they're limited to the kinds of patients that they can take because the city required it. So they are not allowed to take people that have committed any kind of homicide offense, and they're not allowed to take people that have had any sexual offense in their history. I've sort of given you a description of each one, so I'm not going to spend a whole lot more time on this. It does not have that many patients anymore. In fact, actually, these numbers are well pre-COVID. I don't know what happened in Texas, but in California, we had to decrease the census significantly to make COVID protocols to keep people isolated so that so it wouldn't spread throughout the hospitals. But at the time the slide was made, there was over 1,000 patients at Atascadero. The majority of those patients now come from the prison system. The prison is allowed to send people to the state hospital system that they are not able to manage in the prison because of their mental disorder, and so a lot of them go to Atascadero State Hospital. Again, because it's purpose-built, it resembles a prison much more than it resembles a state hospital. Coalinga, I've talked about, there's not much more to say about it. It has 1,500 beds at the time of this slide. Only about 1,200 were filled. Has anybody been to Central California? Somebody here must be from California. You're raising your hand on a lot of this. Okay, cool. He said he graduated from UCLA and USC and worked for one of the state hospitals in California, so he knows the system. There's not much in the Central Valley in California besides methamphetamine and cows. And no, you think I'm kidding. You drive from Northern California down I-5 to Southern California, and you'll pass these steer farms that you will instantly know that they're there because of the odor that you smell, and then you see them, and you're sort of horrified that something could happen like that, especially in California. And then, of course, Fresno used to be the meth capital of the country, although I don't know that it is anymore. But there's a lot of methamphetamine in California in general and in the Central Valley. But the biggest problem was the steer farms, and it's out in the middle of nowhere, and nobody wanted to live out in the middle of nowhere. So they had a really hard time filling positions because it was out in the middle of nowhere and nobody wanted to live there. So they finally have gotten their full complement of staff and are now probably close to, prior to COVID, close to their maximum, which is about 1,500 people. Metropolitan was very small. This is an old slide as well. So it, generally speaking, had only around 800 patients in it. It recently, pre-COVID, opened up a large number of beds to provide treatment for incompetent to stand trial people. I don't know the exact numbers, but I know that, again, all of our hospitals' populations decreased with the COVID restrictions. And then the one that I was at, that has, at the time the slide was made, a little over 1,200 patients. It now has a capacity of probably closer to 1,300 pre-COVID, and the majority of those are forensic patients, and a significant proportion of those are people that are found not competent to stand trial. So you can see, oh, I forgot about our biggest one, actually, Patton State Hospital, which is in the Inland Empire. It's by the mountains in Southern California, is the biggest of the hospitals, and it serves a wide range of patients, but again, primarily IST, incompetent to stand trial, and not guilty by reason of insanity patients. Patton State Hospital does not, or it didn't used to have, civilly committed patients. The only two hospitals in our system that do are Metro, which is the smallest of the hospitals, and Napa, which is the second largest of the hospitals. So, and those, Napa by statute is supposed to be restricted to 20%. So no more than 80% of the patients can be forensic. At Napa State Hospital, that number isn't always consistent, but that's theoretically what we're supposed to be. So very small civil population, which of course brings a lot of problems that we'll talk about. Those three hospitals, Patton State Hospital, Metropolitan State Hospital, and Napa State Hospital, were all built in the 1800s, and very few of them have been renovated. So they were built for the sort of quote-unquote regular psychiatric patient and not a forensic patient. And the environment and the physical structure of the hospitals have caused substantial problems throughout the years at a variety of the hospitals. And some of it, if we have time, we can talk about some of the more significant incidents. So that's our system. Is Texas even remotely comparable to this? Can somebody yell out how many patients you serve on any given day? Okay. That slide sort of shows it all, doesn't it? This is the United States, the entire United States, and what you can see is that in the entire United States, California provides treatment to 37% of the forensic hospitals. If you combine Florida, New York, Texas, and Georgia, who all have pretty significant numbers of forensic patients, you're still only at 32%. And then the rest of the country provides treatment to the remainder of the forensic hospitals. So we have an enormous system, and I have repeatedly said in the 20 years that I have been working in California that that's probably the biggest problem in California, is that it's too big. And being that size brings a lot of problems with it. So now let's turn to talking about what we've done about violence. And this was sort of Dr. Warburton's conceptualization of how we envisioned intervening with violence, and it's one of the reasons that I've had a job for 20 years, is that there's a lot of focus on data and collecting data and understanding the data and then interpreting the data to make changes in the system. So that was going to be her big focus, was talking about how that works. One of my points, and you heard some about it this morning, is that the only way that you get data is by evaluating the people that you provide treatment to. And the way to evaluate the people that you provide treatment to is to conduct assessments on them. So we have two major data sources in California. We have an incident management system that I'll talk about when we get to the data more specifically, that tracks all of the incidents in all of the different hospitals. And we also have an assessment component, so that all of the state hospitals at this point are required to conduct a violence risk assessment on any patient that they provide treatment for, with some exceptions, and we'll talk about that as well, what the exceptions are. That was by no means the standard when I got to California in 2001, and that in fact has only been the standard probably for the past 5 or 6 years, that everybody has to have a risk assessment, and we can talk about the ramifications of that. So the first question is, who are the violent patients? And this is where the data starts to come in. What kind of commitments are the patients that are exhibiting the most violence? What is their length of stay? These were all some of the questions that were asked. What is their age? Younger people are supposed to be more violent than older people, right? What is their gender? Probably most people know the answer to that question, by and large. What kinds of assaults do they commit? Those were all of the kinds of questions that were being asked when I came to California, and I was being asked to help in answering them. The assessment portion, like I said, is very, very important, but that requires training, right? You don't just sort of automatically understand how to assess for violence. Well, you did have one psychiatrist in Texas, but he's no longer with us, that did purport to have a particular skill at assessing for risk of future violence, but I think he died. Dr. Grigson, do you all know who Dr. Grigson is? Raise your hands if you know who I'm talking about. I can't see. So not that many people, but some people do. He was pretty famous, but I think he died several years ago. You need to be trained in order to conduct these risk assessments, right? You can't just pick up a manual and read it and be skilled at conducting them. You need to develop a plan to implement the assessment process. And you also need to figure out what are the best instruments for your particular facility to use. And there are a lot of questions that you need to answer before you figure out what instrument you're going to select. And then you need to decide how to treat that, right? All of the purpose of this, and I don't know if you've heard this yet, but the purpose of risk assessment is risk management. That we, quite some time ago, sort of gave up on predicting violence because we're not that good at it. Anybody that knows John Monahan and has read any of his work knows that we've gotten better. But in the monograph that he wrote and published in 1981, he said that flipping a coin probably provided more accuracy, that we were only right in 1/3 of the time. 2/3 of the time we predicted incorrectly. So flipping a coin would have been better. We've gotten better at it, but that's really not the point of conducting risk assessments, with one clear exception. The point, at least for facilities that are charged with treating people that could potentially be violent, is managing their risk. And so that's the point that California is conducting risk assessments with everybody, and theoretically, by design, up front. So as soon as they come into the hospital, we conduct a risk assessment on them, or as soon as possible anyway, in order to provide suggestions for treatment to manage that risk, because that is the reason that you conduct risk assessments. Has anybody heard about environmental treatment in managing violent patients? Anybody? So nobody has heard of this, or at least I can't see. I'm sort of blinded. Anybody upstairs? I'll talk a little bit about it. When I put these slides together, things were sort of chugging along really wonderfully with the environmental approach to risk assessment, and then it all blew up last week. So I'll give you a little bit of insight into why I think it blew up, and talk a little bit about that portion of risk assessment. But there are environmental things that you can do to manage risk as well. It's not all just about the person. So let's talk about risk assessment. As I just said, the purpose of risk assessment is to manage the risk, not to predict who's going to be violent. There are two approaches to risk assessment. One, I just essentially mentioned it. One is the person-centered, and that's the approach that you all are likely most familiar with. That's where you have a person sitting in front of you, and you do an interview, and you take out your structured instrument, and you score them on them, and you come up with a judgment at the end that you can either give some kind of probability about whether or not they're going to commit a violent act, or you can provide some suggestions to treatment providers about what to do to prevent them from committing a violent act. That's the person-centered approach. That's the approach that almost all of us are familiar with. You've likely used it either in a structured way or a very unstructured way throughout your career in treating psychiatric patients, not just forensic patients. The other approach is the one that I just refer to, which is environment-centered. So you're looking at what's going on in the environment, and that doesn't just mean the physical environment. It also means the interaction of the patient with the staff member, and probably more importantly, the way the staff member reacts to the patient. Those are all critical components in managing risk. So we're going to talk about what is most studied, what is most in the literature, and has been in the literature, as you heard this morning, since the late 80s, early 90s, is the person-centered approach to risk assessment. I'm not going to spend a lot of time on this. I know that you've heard a lot about it, but I'm going to just review briefly about these approaches and what they're used for. And the two in yellow are what you're likely going to be used for. At least it's what the Department of State Hospitals uses risk assessment for. The big one is to providing a guide for treatment, which is why they're now required to conduct risk assessments on admission or as close to admission as possible, so that they can work on intervening with the factors that cause people to be at higher risk of violence. The other component is to determine when they're ready to be released. I'm going to try and get people to answer some more questions. One of them is, and I don't know if anybody knows the answer to this one, do you have long-term patients like we do, not guilty by reason of insanity patients? Yes? Does anybody have any clue what the average length of stay, give or take, is for those long-term patients? Sorry? In any one hospital, so it sounds like Texas does the same thing California does and transfers them from hospital to hospital, is that right? So not just NGI. So the 160 days is more likely the IST people, and the 800 days is more likely the longer term. I've done a lot of research with these people, and I would say that the average length of stay for the first commitment, and we have a conditional release program. I'm assuming you all have something similar to that, where our long-term patients, you don't? Am I seeing a head shake? Okay, you have outpatient commitment, but not like our conditional release program. Just as a total aside, and Dr. Hughes can probably attest to this, we have a fellowship program at UC Davis, so we have between 3 and 5 forensic fellows every year that we train, and one of the first things that I tell them when they come to California, because the majority of them come from outside of California, is that if you commit a crime and get arrested in California, don't plead not guilty by reason of insanity unless you're facing the death penalty, which California still has, even though it hasn't been implemented in a long time. And the reason I say that, although we obviously have the offenders with mental disorder commitment, so that's going to sort of negate some of what I say, but in California, NGI commitments by and large are lifetime commitments, and the conditional release program can revoke you at any point in your life if you're still under their oversight, and generally speaking, you are almost always still under their oversight. One of my research assistants who had some interest in this kept track of the longest that somebody had been out in the conditional release program before they were revoked, and it was 26 years. So they were in the community for 26 years and did something and were revoked and sent back to the state hospital system. And of course, all of you know that the more closely people watch you, the more likely it is that they're going to catch you doing something wrong, right? I mean, that's just, and of course, all of you know, having worked with offenders, that the criminal justice system doesn't catch them for even a fraction of the wrong things that they do. So if you're being watched very carefully, then you're likely to do something wrong that would get you sent back to the hospital. So our commitment lengths are sometimes astronomical, and we have patients at Knapp State Hospital that have been in the hospital consistently for 20 or 30 years without ever being released. And so can you imagine if you were in a hospital in 1990 and they're considering releasing you in 2021, what that kind of culture shock would be? So it's a very interesting system that has sort of gotten out of hand, some because of the policies that were implemented many, many years ago. Anyway, I totally digress. That's not really what I wanted to talk about. The factors in white are not likely things that you will be involved with, at least in your system, and it's prison paroles, especially for lifers. In California, the way to get out of prison if you've had a lifetime sentence, which only happens for homicide offenses typically, now anyway, since our laws changed. And then sentencing for death penalty, and I know that actually is a requirement in Texas, that some kind of risk assessment be conducted for somebody to be sentenced to death. There are several types of risk assessments, and you've probably heard this, so I'm going to try and get through this quickly. There's the unstructured clinical judgment, which is sort of your gut feeling. That's the data that Monahan's study was based on, so that 33% accuracy, 67% wrong, is based on clinical, unstructured, unguided, unknowledgeable, primarily clinical judgment, which most people don't do anymore. Actuarial assessments, do people know what an actuarial assessment is? So that's one that's based completely on numbers. So when they're developed, they throw a bunch of factors into an equation, and the end of the equation is whatever they're trying to predict. The one that I'm going to be talking about is the Violence Risk Appraisal Guide. So what at the end of that one was violent reoffending after one violent offense. And then they subject it to a mathematical analysis and come up with a number, and the factors that seem to me most predictive get into the instrument, and the factors that aren't predictive do not get into the instrument. So the two that you probably have heard of are the VRAG, the revised version now is the VRAG-R, and the Static 99. Have people heard of the Static 99? Anybody? Okay, some people have. Those are the two big actuarials that are still being administered now. The other type is structured professional judgment tools. The one that I'm going to be talking about the most is the HCR20. The other one isn't really categorized as an SPJ tool, but the one that you heard about this morning, the PCLR, which isn't even a risk assessment, as I know that you've heard this morning, is sort of an SPJ instrument. It doesn't allow you to really make a determination about their risk at the end of it, but you can make some good guesses based on the results of the PCLR. We've already talked about that, so we know it's a mathematical relationship. I got into trouble in one of the IRBs that I had to go to because on the original VRAG, if you murdered your victim, you subtracted points from your score, and the higher the score, the higher risk you are, whereas if in your offense you didn't cause any injury at all, you added a lot of points, and the IRB just didn't think that that made sense and wanted to know if I had made a mistake, first of all, and what the reasoning was behind that. And the reasoning is that that's how the data came out for the actuarials. They don't have to understand why it comes out the way it comes out. It just is. The problem with actuarials is that they are all based on historical information, so they don't really give you any information about how to manage the risk because it's all static stuff. So gender often was one in an actuarial instrument, and you can't really, generally speaking, change your gender, not easily anyway. You can't change your history. You can't change how many offenses you committed, which is a big factor in both the HCR20 and the static, or not the HCR20, the VRAG and the static 99. So they don't help you in determining how to intervene with the person, which is what we want to do as treatment providers in a hospital that provides treatment to people that are potentially violent. We want to know how to mitigate that risk. SPJ instruments are not really instruments. They're purported to be guides to things that you should consider when you're conducting a risk assessment. So unlike the unstructured judgment, this is very structured. The HCR20 is very structured, and it gives you a list of the 20 things that you should think about when you're conducting a risk assessment on somebody. The benefit of the HCR20 is that it contains factors that are amenable to change, that you can do something about. So for example, one of the big factors with a lot of our patients at Napa is lacking insight into not only their mental disorder and usually their substance use disorder, but the relationship of those two things to their violence. And so that's often a big problem for the patients that we see at Napa. Another one of the more dynamic factors is symptoms of major mental disorder. So the primary reason in California that somebody should be found not guilty by reason of insanity is because they had a psychotic disorder that either interfered with their ability to appreciate the nature and consequences of their behavior or to understand that their behavior was wrong. And so generally speaking, the two things that interfere with that are either a major mental disorder, generally a psychotic disorder, or severe cognitive disorder. And not much you can do about a severe cognitive disorder yet anyway, but for major mental disorder we have treatments that we can intervene with the psychotic symptoms that cause them to be so dangerous. And so that's one of the factors that is more dynamic in the HCR20. Not based on normative data, there is data now that shows the effectiveness of the HCR20 in any of the SPJ tools in terms of predicting, again, we don't do that much anymore, but that was what the data was based on, is how accurate they were in predicting who would and would not exhibit violence in the future. The SPJ tools require, and I think I mentioned this, that you make a judgment about the person's risk at the end. So you decide whether they're low, moderate, or high risk of future violence. These are the three that I'm going to talk about. Has anybody heard of the cover, the classification of violence risk? One person, anybody upstairs? A couple people upstairs? Okay. You're going to hear a little bit about it early on and then a lot about it later, because we used it at Napa in our research. I'm not going to spend any time on this. You heard a whole lot of good information this morning about the PCLR. It was not a risk assessment. It was not developed to be a risk assessment. It was, until these instruments were revised, one of the big factors in at least the HCR20 and the VRAG. It is no longer, the PCL is no longer required to be administered in either the HCR20 or the VRAG. I'm not going to get into the details of either why it's no longer required or even how to score those instruments. I'm hoping that after the end of my talk today, the majority of you will want to know about these instruments, and I would encourage you to start to take the steps to get some training going to use these instruments, because they can be very valuable in this kind of a system. You've heard about a psychopath. I'm going to really skip through this so that we can get to more of the information. These are prototypical psychopaths. You've heard about all of them, though. You've heard about distinguishing between a psychopath and ASPD. It was revised. One of the big problems with the PCLR when it was developed, it was normed only on men. And so in 2003, new norms were developed. It's, for us, was good because 800 of the people in the new norms were from Atascadero State Hospital. Of course, Atascadero State Hospital is all male, so that didn't help much, but there are female norms now for offenders. There are still no female norms for forensic patients, but it does have some normative data now on females, and it didn't used to. The pros is it's good predictor for certain types of violence in the community. It does have forensic norms in addition to offender norms, but only for males. The cons is that it's only associated with certain kind of violence, and we'll talk about that later, what kinds of violence. You've heard a lot actually, about the kinds of violence that you often see associated with people that are more psychopathic than not. Predictive power for institutions is low. There's some caveats to that, and I suppose we can talk about that later. It sort of depends on how many psychopaths you have, or people with more. We don't really talk about yes or no, psychopathic or not. It's a continuum. You have either more or fewer psychopathic traits. It's very labor intensive, and you also heard that this morning, that it requires an extensive interview and an extensive record review. And imagine if you have 20 years worth of hospital records, how long that record review is going to take. So it's not an easy instrument to administer. Fortunately, like I said, for the HCR20 and the VRAG, you no longer need to do the entire PCL. You can do just one portion of it, and the one portion that you're required to do to score those two instruments is way easier than the major instrument. The Violence Risk Appraisal Guide revised. It now has been revised. It was probably released in, my memory's not that good, either 2013 or 2016. It is publicly available, so you have to buy the book to get all of the information that you need to get. Unless you're good at Googling, then you could probably find it online. But it isn't, you don't have to pay for it. You have to recognize some of the limitations of the VRAG, even though it is nice that it is publicly available. The PCLR is not publicly available. You have to pay for the manual and training. The HCR20 is the same. It is not publicly available. You have to pay for the manual, the forms, the training, all of that. So, but the VRAG is publicly available. It's an expanded version of the original VRAG. The original VRAG was about 685 Canadian offenders. Canada was the source of a lot of our risk assessments initially, because Canada has a better tracking system for their offenders. They have a national tracking system. And I don't know if it's a problem in Texas, but in California, we only get the California rap sheets. And if you haven't heard this yet, this is a touchy subject in California. I don't know if it is in Texas, but you really can't do a risk assessment unless you have their criminal arrest history. You have to have their rap sheet, which is what RAP stands for in California, I'm assuming everywhere. Their record of arrest and prosecutions. You have to have that in order to do an accurate risk assessment with anybody that has a criminal arrest history. So, in California, the criminal justice people don't like to release that to us, but they've sort of been mandated to do it, and I'm not sure if that's an issue in Texas or not. So it expanded the original to a little over 1,200, so it's now 1,200 male Canadian offenders. There were no females in either sample, which means that you cannot use it with women. And I don't know what your percentage of females is in your system. Does anybody have a guess as to how many females you have, percentage-wise, approximately? No guesses? 25? We're about, I think, overall, system-wide, about 20, I think. And so we can't use the VRAG. There's been studies that have been published on the VRAG, and it's just not accurate for women, probably because, obviously, the normative data did not contain women. So, the current one is a follow-up of 5 and 12 years, so obviously we're talking about long-term risk, which may or may not be something that you're interested in when you're worried about institutional violence. So this is 5 and 12 years out. And it does provide probability scores so that you can go to court if you want to, which most people don't. And testify that in 100 people that had a similar range, X percentage reoffended violently in X period of time. And that's very compelling for courts to hear when you have those numbers. It's been a little bit controversial, those numbers, and there's been some literature both for and against, some that it overstates the accuracy and some that is sort of, you know, sure it does, but that's okay. So I can direct you to the literature if you're interested in hearing those arguments. It's highly validated. It's built on numbers, so it's highly validated. It's normed on our population if we're only talking about the men, and it is completely structured. So it should be very reliable. If I give it and Dr. Hughes gives it, we should come up with the same answers in terms of what their score is and the resultant probability of their reoffending violently because of its structure. It has static risk factors only though, so it is not at all useful in helping you develop a treatment plan to intervene with their violence. And it only looks at long-term risk. And in hospitals, short-term risk is often what is most concerning. The HCR20, we've talked a lot about that. It has both static, so it has an H. H stands for historical. Those are the static factors. Those are the past that the person can do nothing about, essentially. The C is the clinical factors. So those are the factors that are the most amenable to change. That's what's going on with the patient right now. In the manual, right now means 6 months, so now and the previous 6 months. And there's 5 C factors, and then the R is the risk management factors, and that's sort of your prediction about what's going to happen in the future if you release them or if you keep them in the hospital, given the kind of treatment programs that you're going to be implementing. It encourages judgment, overall judgment about whether they're at low, moderate, or high risk of future violence. The new version was released in 2013. It's version 3. There were a couple of major differences. Some of the items changed. And as I mentioned, you no longer are required to do the PCLR for the HCR20. The PCLR used to be one of the 10 H factors, and it is no longer. The manual does encourage you that if you have somebody that you think is more psychopathic, that you should probably conduct a PCLR, but you're not required to anymore to quote-unquote score the HCR20. And of course, there's no scores really associated with it because it's your judgment about items. The big criticism of all risk assessments, and you've probably heard this, is that you're looking at group data to make decisions about an individual, right? That's what risk assessment is all about. That's what normed assessments are all about, is that you have a group of people that score a certain way, and in that group of people, there's a certain outcome, and you're taking that group data and applying it to the individual sitting in front of you. And if you ever go into court to testify on these instruments, whatever side the attorney is on that is conducting the cross-examination is going to make that point about these instruments. The HCR20 version 3 tried to overcome that by requiring that you look at how relevant that factor was for the individual that you're evaluating. So you have these standard 20 items that you're looking at how people are sort of falling on all of them, and then after you've looked at how they've all fallen, you think about whether it makes a difference in terms of their violence. And of course, the only way that you can make that kind of decision is by looking at whether it made a difference in their past violence. But that's what you're required to do. So, for example, this is one that we don't use very often in California, but let's say that you have somebody that has, a cannabis use disorder, severe, but none of their violence has been associated with their using marijuana. And you all have heard of Humboldt County, right? Has anybody heard of Humboldt County in California? Humboldt County is the marijuana capital of at least the United States. There's more marijuana grown in Humboldt County than I think the rest of the country. That's probably an exaggeration, but so everybody in Humboldt County smokes marijuana whether they want to or not, because it's in the air. There was a fire you're laughing. There was a fire in Humboldt County last year, and we were all wondering what that smoke was going to be like for the entire county, because the county is filled with marijuana farms. It's the major industry in Humboldt County, and literally everybody in Humboldt County smokes marijuana. Probably everybody pretty much in California smokes marijuana because it's legal there, and they've been doing it even before them. But anyway, I digress again. I apologize. I try not to do that, but sometimes I do. Where were we? On substance use. Substance use is one of the H's on the HCR20. In California, we have a huge meth problem, and so the majority of the people in our system have used methamphetamine, and it's a very negative prognostic indicator because of the psychosis that it causes. I could go off on some other issues associated with meth use in California, but I'll try to not digress too much. But so let's say that our person has a marijuana use disorder, and he's never been violent when he's been smoking marijuana. He just sits at home and eats potato chips and watches TV. His violence occurs when he's psychotic, and only when he's psychotic. And by some miracle, using marijuana doesn't worsen his psychotic symptoms. Now, all of this is probably not particularly plausible, but this is just an example. So he has a substance use disorder, but it isn't at all related to his violence. And that's how the current version of the HCR20 gets out of that group argument, is because you're looking at these individual risk factors that may or may not be present, and you're deciding whether or not it's at all relevant to that individual's exhibiting violent behavior. And that goes into your formulation, which is the other new part about the HCR20, is that, and if you start to use it, and it's a great instrument to use, and I don't have any financial dog in the hunt, is that the saying, about the HCR20? We use it at Napa State Hospital. It's a good way of looking at a person and understanding what their risk is. And so that's why I say that it's a great instrument. But at the end of it, as you start to administer, you start to really realize that sort of people fall into two camps. They fall into the people that have a major mental disorder that is maybe complicated a little bit by substance use, but not really that much. They clearly had a major mental disorder before they started using substances. Methamphetamine isn't causing it, even though that does happen sometimes. And once you manage their symptoms of their major mental disorder, there's very little risk of violence in the future. And then the other camp, which is the people that are more antisocial personality disordered, that are potentially more psychopathic, that somehow got into your system. They're not allowed in California system, and by that I mean by statute. You cannot be antisocial personality disordered and be found not guilty by reason of insanity. And you can't even be voluntarily intoxicated and be found not guilty by reason of insanity. But of course, just as dogs are not allowed on the couch, they get on the couch when you're not at home. The statute is the same. People sort of get in even if they're malingering and are primarily ASPD, and so we're left with having to deal with that. Does that happen at all in Texas? Yeah. I didn't think it was peculiar to California. And I'll show you some data later about the percentage of people that are with us that probably shouldn't be with us. And unfortunately, have y'all heard of the Fuchsia statute? It was in your neighboring state that I'm from, Louisiana. That you're supposed to be, to continue somebody's commitment, you have to be both, you have to have a major mental disorder, and I forget what the second one is. But it can't be antisocial personality, according to the Supreme Court. You can't continue somebody's commitment just because they have an antisocial personality. The Supreme Court left off the disorder part of it. So California courts have decided that the Supreme Court didn't mean ASPD, they just meant if you had some antisocial behavior. And so in California, it isn't enough to get in, and a patient actually asked me that. You can't get an NGI commitment if you only have ASPD, but your commitment can be continued if you only have ASPD, which didn't make sense to the patient, but it's true, because California courts consider that to be a major mental disorder, and so they continue the commitment. Again, I digress, but these are some of the peculiar problems that we have in California that we've been trying to address, and I'm not sure if they're relevant for y'all in Texas. So those are the two sort of kinds of patients that we have at Napa, and that's simplistic, and people are much more complex than sort of lumping them into two categories, but those are sort of overarching the two things that the HCR20, the two kinds of people that the HCR20 sort of reveals as you're going through the items. So it is really helpful in terms of formulating what places people at risk. It has both static and dynamic, of course, so that's a good thing. It can guide treatment. That's also a good thing. The bad thing is, not unlike the PCLR, very labor intensive. You really have to know the individual. You have to review their records, and you have to do an interview to understand what's going on with them currently. I've had, on one occasion, because in the research study that I'm going to be talking about soon, one of the requirements was that we do an evaluation before the people were released into the community. One of the other requirements, because of the IRBs in California, is that we weren't allowed to discuss the results of any of our evaluations with the treatment teams. So we had to conduct these interviews in isolation, and one of my research assistants came to me after interviewing a patient that was going to be released within the next week or two and had serious concerns about how still ill he was, but that nobody had spent any time with him recently to understand that he had gotten ill again. He apparently was fine for a while and then had gotten ill again, but in between when his discharge was approved and when he was going to be discharged, which sometimes can take 6 months in California, if not longer, he had decompensated and gotten sick again. And I couldn't do anything about it. I had to let them know, but I actually have great faith in our conditional release program, and I knew that they had lots of oversight, and he was back within 24 hours because he was so ill. So they're labor intensive is the sort of punchline to that story. And knowing the patient really, really matters. You have to spend time with them to understand what's going on with them. Did somebody ask a question? Nope. We weren't allowed to release it to anybody. I know. It was terrible. It's the IRBs. It's the trials and tribulations that I had when I started in California in conducting research with these individuals, I could spend hours talking about. I'm hoping that some of my talk will motivate you all to start some of the programs that we've started at Napa and throughout the state to help you understand better what's going on in your system. But for us, we had to go through the IRBs, and I started in the year 2000 and 2001, sorry. And that was at the time where the IRBs started to recognize that the federal guidelines for research with prisoners applied to forensic populations. And so they held me to the standard for the federal guidelines for research with prisoners, which is very complicated guidelines based on previous atrocities that were conducted in the name of research with prisoners throughout the country, California being one of the states, but everywhere in the country. And so one of the requirements is that you not base release decisions on their participation in research. So really the point of that was you can't tell a prisoner if you volunteer for my research, you can get out 6 months early. You're not allowed to do that anymore because of what happened years ago. The IRBs interpreted that to mean that I couldn't tell them anything about any of the evaluations I did that would impact their discharge. So that's why I wasn't allowed to tell, or I would have been in violation of research protocol at UC Davis. So, which I know sounds terrible, but I truly did have faith in the conditional release program, and I knew that they would immediately recognize how ill he was, and they did, and they brought him back. The last one that I'm going to talk about is the classification of violence risk. This is a program that we started at Napa, and I can tell you a little bit about that and will tell you a little bit about that. This is the instrument that was based on the MacArthur study of violence risk. Has anybody heard of the MacArthur study of violence risk? It was a study that was a big deal when I first started in forensics. It was started sometime in the 90s, and I can remember the very first Apple conference I went to in 1995 or 6, something like that, where Renee Bender, who's a prominent forensic psychiatrist in San Francisco, her task at every Apple was to report on the progress of the MacArthur study. And it finally was completed. It is a study that was conducted on civil psychiatric patients. Did somebody have another question? No, I'm hearing voices. Okay. That's not atypical. Well, I'm joking, actually. Anyway, it was a study that was supposed to sort of correct all of the problems of other violence risk studies, and it was a very comprehensive study. Lots of instruments were developed. The PCLSV that you heard about this morning was developed specifically for the MacArthur study of violence risk. Out of it came this instrument, which is called the Classification of Violence Risk. It is based on an iterative classification tree. Does anybody know what that means? I didn't, so I don't really expect anybody to, but it's a fancy statistical procedure that they claimed was superior to logistic regression, which is another fancy statistical procedure that I won't go into the details about because I do want you to stay awake. Like I said, it was developed on civil psychiatric patients, so there's some concern about the applicability of an instrument that was developed on civil psychiatric patients to forensic patients, and so I got some pushback from some people when I started using it in my study. Well, not then, but later. It's a brief interview. It's a lovely instrument because of that. It only takes about 15 minutes maybe to administer. It's totally computerized so that you sit in front of a computer and you ask a series of questions. A lot of them are the same for any patient sitting in front of you, but some of them are different depending on their answers. So how they answer questions drives what the next question is going to be. There are about 40 risk factors in it that were the most predictive in the MacArthur study. And it only theoretically, I know this not to be true based on my knowledge of risk assessment, but theoretically it only has you ask questions that are adequate enough to classify the person. So, and generally speaking, that's true. And generally speaking, it really does only take about 10 or 15 minutes. There's a record review that's required, but it literally takes 5 minutes to do the kind of record review that they're talking about. So the pro is that it's very easy to administer, and you'll hear about a program where we used it at Napa State Hospital. It provides a numeric risk estimate, and so people really like that. So you get a number that you push a button and it gives you a score, and the score is either a 1, which means that only 1% of the people would exhibit a violent act, an 8, so 8% of the people, a 26, which is average, a 56, so higher than average risk, or a 86, which is the highest risk. So it gives you a number that tells you what their risk is of exhibiting at least one act of violence that's very specifically defined by the MacArthur Foundation people in the next 20 weeks, which is how long the study was conducted to arrive at the data to develop this particular instrument. The MacArthur study itself went on for 50 weeks, actually. The biggest con is there's no recommendation for treatment. The other huge con is that there's absolutely no information provided on what places that person at risk. So it really doesn't help in terms of developing a treatment program for them. So what have we learned so far today? We've learned that there's a range of risk assessments that you can choose from. I've actually only mentioned 3, really. The PCL doesn't count. There are many, many other ones, and it really depends on how you want to use the risk assessments. These that I've spoken of, I mean, even the MacArthur one, the cover is 20 weeks, so that's longer term than what lots of time the question is, which is this person walking in the door going to be violent over the next week or so? Is there anything that we need to do? And there are instruments that you can administer to answer that question, short-term risk. But the ones that I'm talking about were mostly long-term risk. PCLR, the VRAG-R, the HCR20, and the cover are the ones that we covered, no pun intended, today. Okay, so that's one part of the equation. The other part of the equation is if you do this, then what does it mean? And so that's where I'm going to start to talk about what we did at Napa State Hospital when we first got there. In order for you to understand some of what went on at Napa State Hospital, it's important for you to understand the hospital. So I'm going to try and provide that information briefly. Napa State Hospital, I think, was built in 1885, so it's very old. It's been around for a very long time. It has, until 1997, been a hospital that provides treatment for primarily civil psychiatric patients. I don't know how long ago the last voluntary patient was at Napa State Hospital, but it's been a pretty long time ago. There haven't been voluntary patients in a long time, so most of them were civilly committed to Napa State Hospital. Come mid-1990s, the system started becoming way more forensic, and Napa State Hospital was told that you either become a forensic or primarily forensic hospital or you close. And so the executive director had to decide what to do. And of course, what do you think his decision was? His decision was, of course, to stay open, but he didn't get rid of any of the staff. So the staff, who were all hired to provide treatment to essentially just sort of regular non-forensic patients, were now required to provide treatment to people with violent criminal histories. And it's a totally different thing to do, to have to take that into account. Psychiatric hospitals have violence as a problem across the country, regardless of whether they're forensic or not, but the criminal arrest history just provides an added risk and concern. So, and there's a variety of concerns that are associated with providing treatment to forensic patients. My understanding is that you had somebody here talking about boundary issues with providing treatment to forensic patients, and that came to be a big problem at Napa State Hospital. I have several probably not particularly funny stories about boundary violations that happened between patients and staff that didn't end well for the staff member, obviously. So there was a whole program actually that was developed with UC Davis to help transition this staff into a staff that was knowledgeable about providing treatment to forensic patients from a staff that was knowledgeable about providing treatment to patients that didn't have a criminal arrest history. My part in it began in 2001 when I started there. We got our first study approved by the IRBs, which took several iterations to do. In 2002, it was focused on violence because that was becoming an increasing problem at Napa State Hospital because of the conversion to forensic patients, A. B, also because of the recognition that seclusion and, more importantly, restraints were not the best mechanism for managing violent patients, and that was becoming a problem in California with a requirement that the use of seclusion and restraints be reduced significantly. So that was my job when I got there, was to develop some kind of research protocol that would help answer some questions about the patients that were there, what to do about them, how to intervene with their violent behavior. So it started in 2002, and I could go on for hours about the problems with getting it started that don't involve the IRB, but I won't do that either. Our plan was to recruit to a research unit. It was a really progressive executive director that decided that he was going to designate one unit that was going to have all of the research done on it. That turned out to be a good idea with good intentions that absolutely didn't work for reasons not worth going into right now. I can tell people off the stage at some point if they're interested. So we were mostly looking, in fact, we were exclusively looking at the long-term patients. Violence obviously is a problem for our IST patients, but we're not supposed to keep them as long to really worry about it as much in the long term. And the primary treatment for IST people is to restore them to competence, which usually means treating their psychotic symptoms so that they're not psychotic anymore and they can work with their attorney and understand what's going on in the courtroom. So that's the quicker way to get them back and out of the hospital, and doing risk assessments still actually isn't done on our IST patients, with some limitations that I'll talk about. So we administered all of the instruments that I was talking about. We administered the PCLR, we administered the HCR20 version 2, not the new version, the older version. We administered the VRAG, the old version, not the new version. We did this with men and women, and in my study, quite frankly, the VRAG worked fine with women, but there's a lot of studies that show that it doesn't work with women. In mine, it didn't seem to make a difference. We also looked at psychiatric symptoms. We used the brief psychiatric rating scale. Is anybody familiar with the BPRS? It's been around since the 70s. It's an instrument that is used widely in clinical trials for medication, and so we use that to quantify the psychiatric symptoms of our patients. And we also, partially because the MacArthur group used these instruments, we used the Barrett impulsivity scale and the Navaco anger scale, because impulsivity and anger are two critical factors in violence and violence reduction, so we included those. Those two are self-report instruments. We wanted to know if these instruments that have been primarily at that point, and so remember this was almost 20 years ago, 19, but who's counting? We were interested in whether they worked for institutional violence. The majority of the research 20 years ago was based on community violence. So we were really interested in looking at whether they were as predictive in the institutions as they were in the community. So I've already told you what we used. The brief psychiatric rating scale, very briefly, is an instrument that contains 18 items, and it can be broken down into 4 subscales of psychotic positive symptoms of psychosis, delusions, hallucinations, negative symptoms like anhedonia, hostility, so being hostile, angry, suspicious, and depressive symptoms, anxiety, guilt, depressed mood. So we quantified all of the individuals in our study on that instrument. We also had them take the Navaco anger scale, which has 3 subscales that evaluate angry thinking, sort of arousal level, and angry behavior. And this one was self-report, so there are limitations with self-report instruments, of course. There's also a provocation index that looks at their anger, their ability to regulate their anger, and their how provoked they get when they get angry. The Barrett impulsivity scale also has 3 subscales for cognitive impulsivity, sort of thinking impulsively, motor impulsivity, and problems with planning their behavior. Some of these questions, this was an instrument that was developed for people that are not inpatients. inpatients, not inpatient, but inpatients. So one of the questions is something along the lines of, I like to plan vacations. That's not particularly relevant for our patients anyway. They're not allowed to go on vacation. Well, they're not allowed out of the hospital anyway. The system has changed in the 20 years that I've been there. Do you have a system for tracking aggressive acts in your hospitals? Yes or no? Yes? We had an interesting system until 2010, and it was a paper system. Things have become completely electronic, with the exception of the medical record. That's still, do you all have a medical record, electronic medical record? Yeah, we don't yet. Someday. I'll be long gone, probably. Initially, the nurses are required to write up an incident report every time something atypical happened. Atypical was never really defined, and so a lot of stuff wasn't captured. The administrative directive, which are the policies that direct how things are supposed to be done, was eventually changed, so they were required to write up everything. It still didn't always happen, so our civil psychiatric patients that comprise 20% or less of our hospital, and whenever I say our, I mean Napa, account for about 50% of the incidents of aggression in our hospital, because we have found the civil psychiatric patients are the patients that can't be managed in the community, and they are often more violent and repetitively violent, and the nursing staff sometimes get sort of complacent, and unless it's a serious act of violence, they don't always record every act of violence, even though the administrative directive said that they were supposed to. But by and large, that's how it worked until 2010, when the electronic incident management system took over. There's one hospital that still doesn't do the electronic incident management system. It still does the paper. Special incident reports, or SIRs is what we call them. And then they're entered electronically, but they don't use the electronic system. But the rest of the hospitals do use this electronic system that essentially mirrored the paper system. It just took some training to get people to learn how to use the computer system, because it wasn't the most sort of user-friendly system. This is data. I'm going to have a few data slides. This was early on in the research where we were doing all of these assessments, and we were looking at the relationship between the various things on the assessments and the measures of aggression that we had. And what we found is that we had 4 types of patients. And these graphs show you what the 4 types are. The line, the 0 line, is the average. These are Z-scores, which means that the average score is 0, and anything positive is above average, and anything negative is below average. So what you can see is that we had the cluster in the red, where they scored really low on the violence risk assessments, but they scored above average on the measures of impulsivity and anger. So that was one type of patient we had. So low on the risk assessments, but sort of impulsive and angry. And we had women in here too, by the way. The next cluster was the yellow cluster, where they were sort of average across the board, but lower on anger. So they sort of scored in the average range on the risk assessment, average range on impulsivity, but weren't very angry. So didn't get provoked very much by anything. We had the people in green that I often say begs the question of what they needed, what they were still doing in the hospital, but because they scored below average on everything. So low on violence risk assessments, low on measures of impulsivity, low on measures of anger. And then we had the blue line, where they scored above average on everything. They had higher violence risk assessments than anybody else, comparable to the red bar in terms of impulsivity, but higher anger measures. And so what does that mean? How did that translate? And this is how it translated. And I put cluster 4, or the high people, because cluster 4 are obviously the people causing the majority of the problem in the hospital, and especially the majority of the problem for staff members. They were the most violent patients against both other patients and particularly against staff members. And so that was information that was very useful to the administration in terms of understanding at least a little bit. But we didn't stop there. I'm going to stop here because I've talked a lot and make sure that nobody has any questions, and also to check on the time to make sure I'm not keeping you beyond when you're supposed to break. And this is when we were supposed to break around. So does anybody have any questions about any of this? There's a question somewhere? High on the risk assessments, above average on impulsivity, above average on anger. So they were high across the board. So they were higher risk, impulsive and angry people. Highest risk towards staff, for sure, yes. Which make, go on.
Our patients, by and large, have not been adjudicated yet. And so, as you can see, we have a maximum security environment with a big fence to keep people in. In the pictures, I didn't notice any large fences or other devices to keep people inside at the Napa Hospital or the other hospitals. So tell me what you do to make sure that people do not attempt to elope before their cases have been heard.
Yeah, I didn't mention all of that. The community was not at all happy when the executive director made the decision to convert to a forensic hospital. So you think of Napa, you think of wine and rolling hills and vineyards. You don't think of razor ribbon and the other things that had to happen in order to house, to provide treatment for people that have serious violent felonies in their record. The Napa was only allowed to take medium risk patients. That sounds great, but it doesn't mean at all, in all likelihood, what you're thinking. Medium risk is risk of escape. So, so that was one limitation. In terms of risk of violence, that wasn't even assessed and wasn't even thought of. So razor ribbon went up, which was new. They had Sallyport. It's a secure way of getting in and out of the hospital. They had hospital police officers. Their force increased like 10 times with kiosks around the perimeter to make sure that people didn't escape, because the primary risk was of escape. That was what moderate risk meant. And anybody that wanted a one-way ticket out of Napa State Hospital just had to fling themselves at the fence. It had a wire going through it. It wasn't an electrical fence. It was a shake wire. And so if you flung yourself at the fence, then an alarm would go off with hospital police, and they would come running to wherever the alarm said that it was going off, and get the person. The only interior security was a not particularly effective alarm system that staff carried around. So if something happened, they had this mechanism that they would push the button, and you hoped that it went off, and then people would come running. It didn't always. And I knew a psychiatrist and psychologist who ended up in an altercation with a patient, and their alarms didn't work. It did not help, and I don't know if this has been a while now, but probably you heard about the murder that happened at Napa State Hospital, where one of the nursing staff was murdered by a patient. And she was outside, and the alarm system didn't work outside. So that got changed, and Napa State Hospital was the first hospital that got a GPS-activated alarm system that worked both inside and outside the hospital, exclusively because of that murder that happened. So it was a process that took a long time I mean, that murder happened in 2010, and I don't think the GPS-activated system was in effect until probably 2012. So it took a couple years. The hospital was on lockdown until that came into effect. So it's been a lengthy process that's still, nobody's perfect, and Napa isn't yet either. Was there another question up there? We didn't specifically look at length of stay for any of the clusters, so I don't have that. I could probably find that for you if you were interested in that. My hypothesis was that, and at the time that I did this research, the hospital was divided into various different kinds of units, one of which was a discharge unit. One of the problems with how the system was set up was that this is a long-term hospital. The patients that we were recruiting were long-term patients. And with long-term patients, they get in treatment with a certain treatment team, and they don't necessarily want to leave that treatment team to participate in a research program. So we had lots of problems recruiting patients to the research unit, and it took years to do it. And finally, with permission of the IRBs, we were able to recruit off what were called the open units, which were the patients on units where the doors were unlocked, so they had free reign of the hospital. They could go wherever they wanted at certain times during the day. They obviously did want to transfer to a research unit, and we also were able to recruit patients from long-term locked units as well that were not able to transfer to the research unit because the research unit was a co-ed unit. So I always suspected, and I wanted to tell you that to explain your question, that these were probably patients on the open units that were much farther along in their treatment, so their length of stay was probably longer than the other clusters. So good question, though. Okay, so we'll take a break, and we'll try and keep it to 15 minutes. I'm from New Orleans, so hopefully that doesn't mean 30, but maybe closer to 20, but 15 if you can manage it. We'll see you all in a little bit.
Please welcome back Miss Dr. Barbara McDermott.
Okay, I'm sure people will straggle in, but I have a lot more to talk about, so I'm going to get started. Just wanted to summarize what we've learned so far, at least in that particular session, is that risk assessments can help. And, but it's not just the risk assessments, that other symptoms are important as well. Okay, so we've learned some. This was probably a result of about the first 7 years, what you just saw, what I just talked about. And so I'm still there, so they kept me around. They had more questions. There were more questions. So we learned a little bit about the kinds of patients that we had. We learned a little bit about what, who was most likely to exhibit aggression. And we learned that aggression towards staff was a problem for that particular group of patients. But there was so much more that we needed to understand. And so that's when a colleague of mine came into the picture. He had been reading about other psychiatric hospitals and read about a typology of aggression that he found intriguing. And I think you heard a little bit about it this morning when Dr. Shipley was talking about the PCL, that there are a couple of different kinds of aggression. Well, there was one particular researcher in New York who started looking at the kinds of aggression that you see in psychiatric hospitals, not just forensic psychiatric hospitals. And she had a pretty innovative way of looking at it. She videotaped acts of aggression. She had cameras actually in all public areas of the hospital that she was looking at. And in addition to videotaping the acts of aggression, she also interviewed both the witnesses, the assailant, and the victim of the aggression to get their sort of perspective on what had happened. So she had the independent videos and she had interviews with the people that were involved in the aggression. And what she found is that there were 3 primary categories of aggression that she saw in the particular hospital that she was at. One was impulsive aggression. I think Dr. Shipley also called it reactive aggression, and we'll talk a little bit more about that. One was psychopathic or planned predatory aggression, which obviously, as the name implies, you would expect to be exhibited more by people that score higher on the PCLR. And then one peculiar to psychiatric hospitals that is aggression that's driven by underlying psychiatric symptomatology, particularly psychotic symptomatology. And so Dr. Quanback was my colleague who was interested in this. Thought, you know, I'm going to see if we can replicate this at Napa State Hospital. So what he did was he pulled about 1,000 incidents from the then paper incident management system and looked at what was going on with those acts of aggression, the 1,000 acts of aggression. This included not just the forensic patients, it was also the civil patients, and in fact, the likelihood is that there were more incidents per patient from the civil patients than there were incidents per patient from the forensic patients. So it's likely that there were more civil patients in his sample. And he found that in Napa State Hospital, that 54% of the acts of aggression that he had looked at were categorized as impulsive or reactive aggression, that 29% were planned or predatory aggression, and then only 17% were psychotic aggression, which means that it was aggression that was driven by psychotic symptoms. So somebody believing that somebody was stealing from them and assaulted them because they were under the delusional belief that they were stealing from them. which I suppose is a good thing. Only 17% of all of them were psychotically driven aggression, which means that the hospital was treating the psychotic symptoms. And so that is why that was the smallest percentage of aggression that he saw in his sample. He looked at the relationship between the type of aggression and who was the victim of the aggression. And what you can see here is that impulsive aggression was the type of aggression that was most likely to occur towards a staff member. And we're going to go through the specific sort of drivers of the different kinds of aggression, and I think that you'll start to see why that's the case, why staff members are more likely to be the target of impulsive aggression, especially as compared to patients, and that it is the aggression that is most prominent with staff members. So he defined impulsive aggression as unplanned, loss of control, response to a provocation, agitated state, all kinds of different descriptors that you could probably come up with. What was most important with Dr. Quanbach's data was that he tried to actually categorize what the trigger was for the impulsive active aggression. And these were the categories that he came up with. Bothered, so I don't know how, again, it works in Texas. California, the units are incredibly large, so the smallest unit that we have at Napa State Hospital pre-COVID, it's not true now during COVID, but pre-COVID, the smallest unit was 33 beds, and the largest unit is 65 beds. So those are really, really big units, and one of the things that happens in these units that are this size is that patients are required to line up for all kinds of things. They're required to line up to get their medications. They're required to line up to get to the dining hall for meals. They're required to line up for a number of things. And that simple process of lining up causes problems because they're in close proximity with each other. So bothered means you're standing in line and the person behind you inadvertently bumps you and you're having a bad day and it pisses you off, so you turn around and you slug them. That's the trigger for that kind of aggression. That happens often with this lining up, and the hospital knows that it happens with this lining up, but it's the most efficient way to get the patients in to the things that they actually need, and so it hasn't stopped, but stopping that would probably eliminate some of the aggression, the impulsive kind of aggression that we see at Napa State Hospital. But the two biggies, especially towards staff, are being directed to do something or being denied something. So the patient comes up to the nurse's station and asks for anything, you know, the bathroom door to be unlocked because they have to go to the bathroom, and the nursing staff says, hold it a second, I've got something else I need to do, and the patient gets angry and irritated and strikes out at the staff member. And the other one is being told to do something. So you need to stop doing that and go spend some time in your room or something like that. So those were the two biggest causes of aggression against staff members. To a lesser extent, the denial against other patients. So a patient asks another patient back before 2008, can I have a cigarette? And the other patient says, no, I'm not giving you any of my cigarettes. And so the first patient that's asked gets mad and punches them. So that scenario doesn't happen anymore because smoking hasn't been allowed on campus since 2008. Is that true in Texas? Are you allowed to smoke? No? Okay. I figured it got eliminated pretty much across the board in most. I don't think it's eliminated in prisons, but I'm not sure about that. Anyway. And then these other ones are much less. So sometimes there's an assault that happens as the staff are trying to put the patient into restraints. And so that would be one of the impulsive ones where the patient's irritated that they're being put in restraints and lashes out. That happens less and less as we use the restraints less and less at the hospitals. Being insulted, so somebody calls you a name and you get mad and you lash out. So those are the different triggers that Dr. Quanback found for impulsive aggression. And looking at those categories, it makes perfect sense that staff are the primary targets of impulsive aggression, right? And he even found directed is 26% of the impulsive aggression and denied is 19%. And then the others are much lower than that. We talked about this, that these are sort of the different examples, so I'm going to sort of zoom through this because I know that there's some other questions that I want to make sure that we get to everything. And I've already given you these examples. So planned aggression is described as being organized and premeditated. One of the criteria that we had at Napa is that psychotically driven aggression trumps everything. So sometimes psychotically driven aggression can be planned, right? So you think that your roommate is stealing your thoughts, and so you assault your roommate after thinking about it for a while and getting sick of him stealing your thoughts. You set up a plan to attack your roommate, but it's all based on a delusion that your roommate is stealing your thoughts. So that would be, in our system, even though it was a planned predatory attack, it was driven by psychotic symptoms. So we would categorize that as more related to psychotic symptoms, and that drives treatment, right? If it's related to psychotic symptoms, then the treatment is to reduce the psychotic symptoms, not to try and reduce their planned predatory behavior. Does not have a large emotional component. That's yes and no, actually, in terms of predatory aggression, but by and large, it's described in the way that Dr. Shipley described it this morning, that it's sort of cool, calculated aggression. It sometimes can be related to social gain. I don't know if that's the case with your patients here in Texas, but we do have our share of individuals who score much higher on the PCLR, who are much more psychopathic and antisocial than they are major mental disorder, and there is definitely a hierarchy among them. Some are the ringleaders and some are not. So if there's any competition between the different psychopathic individuals and they're trying to assert who's dominant, then that's the type of aggression that you'll see with them, that is very predatory in nature in sort of trying to establish who's boss in the hospital. Target is usually focused. It can be influenced by group pressure. There's all kinds of characteristics. Cold threats, have you all heard of cold threats here? Anybody, raise your hand. We actually don't see it a lot, but it's when the patient threatens your family, for example. So if you don't do X, Y, and Z, I know where you live, is kind of a cold threat, and it definitely has happened with some of our patients and staff at Knapp State Hospital. It can be for retaliation, that's cold threat, extortion. Sexual is usually always predatory. It's very rare that sexual aggression, at least in our hospital, is related to psychotic symptoms. Racial is probably more gang related. Do you have gang problem in your system at all? Is there any problem with gangs? There is in California, and there definitely is in our state hospital system. In fact, the hospital police officers make a point of noting what gang members are in our hospital and what gangs they belong to and trying to keep them off of the same units, because there's two big ones in California that are the Norteños and the Northern Hispanic gang and the Southern Hispanic gang. I forget what the name of the Southern one is, and they hate each other, and if they're on the same unit, then there's likely to be significant aggression. These are the various motivations. Again, I think all of these are in the slides so that you can see what some of the motivations are. I'll be talking about some of this later on, and it'll become a little bit clearer for you. So psychotic, also categorized as medical aggression. Do you have people with severe cognitive problems in your system at all? Yeah. At Knapp State Hospital, we have a SNF, a skilled nursing facility, and so a lot of the patients on the SNF have severe cognitive problems like dementia, and anybody that's worked in SNFs understands that oftentimes because of the cognitive decline that they sometimes get aggressive. So that would be categorized in this kind of aggression as well. But primarily it's aggression related to their delusions and hallucinations, like somebody hearing a voice that says that their roommate is going to kill them, and so acting out because of that. Generally speaking, there's no rational alternative motive, although the example I gave previously, it can look very planned and predatory because it is, but it's driven by psychosis, not by wanting power or dominance or social control. And these are the kinds of motivations for psychotic assaults. The highlighted in yellow are the ones that were most common, and what Dr. Quanback saw as the biggest factors. So what we've learned here is that you can categorize. What we're going to learn next is, and that might drive treatment, but what we're going to learn next is if and how the risk assessments are related to these types of aggressions. So we had that established by Dr. Quanback, that this typology that Dr. Nolan developed in New York was relevant for our patients. And so now we're going to look to see if any of the assessments that we administered in that prior study that you saw the clusters for is relevant in the relationship between the risk assessments and the different kinds of aggression. So just to see if you're paying attention, what would you expect? You now know what instruments I've administered, right? We've administered the PCLR, the HCR20, the VRAG, symptoms of anger, impulsivity, and psychiatric symptoms. What do you think would be the highest relationship between any of those measures and predatory aggression, based on what you heard this morning, if that's a clue? PCL, yeah. So let's see. First, what we found is for current, and current I mean the data that I collected from our patients, we found that it was very similar to what Dr. Quanback found, that 45% of it, the majority of it, well, not the majority, but the biggest percentage was impulsive aggression, much less for organized aggression, but not great actually. 27% is not nothing, and so that's sort of a problem. 15% for psychotic, and then 13% there wasn't enough information on the special incidents reports for us to really categorize it. Let me back this up. You all don't do the PCL, right? Right now anyway, as far as I know. And we don't do it on everybody. Truthfully, it's very laborious and takes a really long time. I guess those are the same thing. But I did it on all of the patients in my study, and what we found is that about 20% of the men, just the men, the PCL doesn't work the same way with women. Psychopathy in women is a little bit different than psychopathy in men. But about 20% of the men scored 25 or higher on the PCL. It used to be that the cutoff for being considered, quote, a psychopath was 30. For research, people usually use 25 as sort of indicating a pretty high level of psychopathy. We don't use that cutoff anymore because is 29 on the PCL really that different than a 30? Probably not, especially if you know the instrument. So, but 29 and 30 are people you don't really want to meet in a dark alley anywhere. That's really high for people that theoretically, I mean, remember that these are all people that were found not guilty by reason of insanity. A smaller percentage were the mentally disordered offenders or offenders with mental disorder that were sent from the prison system. But you would not expect a forensic sample to have that high a percentage of people with that high a score on the PCL because of the nature of the kinds of commitments that we get at our hospital. And what that means is that a significant percentage of them probably malingered their way into an NGI commitment, which is not uncommon in California, unfortunately, and hasn't become less common over the years either. This is a very busy graph that really I just wanted to show you, if you look at the middle part, the predatory aggression, that the two biggest groups of people exhibiting those kinds of aggression are people with a primary diagnosis of a substance use disorder, shouldn't happen in an NGI sample, or a primary diagnosis of what used to be called psychotic disorder NOS, which other research that has been done at DSH Napa State Hospital, suggests that often those people that have a primary diagnosis of psychotic disorder NOS are people that really have a substance use disorder. I mean, they're people that don't meet the full criteria for schizophrenia, right? And usually they're saying they have hallucinations, and often those are substance induced. So there's a lot of overlap between substance use disorder diagnoses and psychotic disorder NOS, which unfortunately was changed to schizophrenia spectrum and other psychotic disorders, unspecified or specified. And I think that gives people a little more flexibility in using that diagnosis because it has schizophrenia in it. That's just my opinion though. Anyway, that's what I wanted to show you with that. And those people, substance use disorders, that's prohibited for NGI. You can't be voluntarily intoxicated and be found not guilty by reason of insanity. This one shows that the primary, and I had to change the titles on these. I developed these slides several years ago before DSM-5 came out, and we don't talk about Axis 1 and Axis 2 anymore, although people do still talk about Axis 1 and Axis 2. But we're talking about personality disorder diagnoses. And of course, with predatory aggression, the biggest personality disorder diagnosis for those individuals is antisocial personality disorder. And this shows it in relationship to the PCL. And again, as you can see here, the PCL scores were very high for the people that exhibited predatory aggression. So your guess would have been right from this morning. The problem is, and this slide shows that, is that what our research has shown is that even though impulsive aggression is the most frequent kind of aggression, predatory aggression is the most dangerous kind of aggression. And it is the type of aggression that causes the most severe injury. So the murder that happened at our hospital in 2010 was an act of predatory aggression against the hospital staff member. So, and there's been, unfortunately, a couple of murders of patients in our hospital, and the one person committed 2 of them actually, and both of them were predatory acts of aggression. So it is very, very dangerous kind of aggression, which is really why people with antisocial personality disorder as their primary diagnosis shouldn't be committed to a hospital that has patients with major mental disorders that are much more vulnerable to these kinds of attacks. But this is the data, and this is what the data shows in terms of the relationship between, these are correlations. So a 0 means there's no relationship between the factor and the type of aggression, and a 1 means that it's a perfect relationship. And what you can see here is that this shows that the PCL is really good at identifying people who are more likely to commit an act of predatory aggression, coupled with anger. So they have to be angry about something and more psychopathic to exhibit an act of predatory aggression. For psychotically driven aggression, it's not surprising. The impulsivity scale on the Barrett impulsivity instrument was highly correlated, as were positive symptoms of psychosis. But that's sort of the definition of psychotically driven aggression, so that one's not surprising. Did somebody have a question? Impulsive aggression, the correlations aren't as high. They're much weaker than the other two because they're not as strongly related to things. So the HCR20 was good, the Navaco anger scale was good, and the interpersonal facet of the PCLR was good, but none of them were great. So we're not as good at predicting impulsive aggression or identifying who is more likely to exhibit impulsive aggression, but that makes sense because impulsive aggression, by definition, is sort of spur of the moment, acting out in anger kind of aggression, acting impulsively. So it makes sense that it would be more difficult to predict. The problem is that it is the most frequent type of aggression, so we're hoping to get better at it. This is just a translation of the slide. So predatory aggression comes from people that are more psychopathic and results in more injury. Psychotic aggression, by definition, is related to psychotic symptoms and impulsive people. And impulsive aggression are the weakest, has the weakest correlates. So it's more than just the person. So one of the problems, and I've heard this in a lot of places, I know that I'm sure, I don't know, but I imagine that it's a problem here, is that all of these assessments are labor intensive. They take a really long time. The VRAG probably takes the least amount of time, but it still takes a while to read the records and get enough information to do the scoring. And the VRAG, you know, has been a little bit iffy and certainly doesn't help you in terms of deciding what kinds of treatments to mitigate risk, so, because it's all static factors. So none of them are useful for a screening tool, and that's, of course, one of the important things, is the stranger walks into your door, and you probably get records, we do, on our patients before they come, but records don't always tell you everything. You know, we usually have sheriff's departments transporting the patients, and they'll tell us what their behavior is like if it's problematic on the transport in from the jails. But sometimes we have minimal amount of information, and so we want to know more about what's going to happen with these patients once their feet hit the door. So in my study, we initially conducted the study with those 3 assessments, the PCL, the HCR20, and the VRAG. Later on, the cover was developed and was published, and so John Monahan allowed me to administer the cover for a reduced fee because it was a part of a research program. So we got to administer the cover on every patient that we had in our study, and as many as would cooperate with us. And this is what we found, the relationships between the various instruments and the cover score. So the PCL total score actually was pretty highly related to the final cover score. Remember, there's only 5 scores that come out of it. The HCR20 was okay. The VRAG actually was pretty highly related, and there weren't particularly good relationships between psychotic symptoms or any symptoms as measured by the BPRS, impulsivity, or behavior. Does anybody know the MacArthur study really, really well? Probably not. The iterative tree of the MacArthur study that produced the cover is a statistical program that sort of looks at what would best describe groups. And remember, I said that the PCLSV was developed for use in the MacArthur study, and in one of the decision tree analyses that the MacArthur group conducted, the very first dividing point was the PCL. So it was the strongest predictor in the MacArthur study was the PCL score. And so that's probably why the PCL was so highly correlated with the cover score, is because it was developed sort of based on the PCL, if that makes sense. Does that make sense to what I was saying? The other thing, and I presented these data at an Apple meeting several years ago, and Paul Applebaum was in do you all know who Paul Applebaum is? He's a prominent forensic psychiatrist, and he's one of the authors of he was in the MacArthur study, and he's one of the authors of the cover, and so he was interested in how the cover came out with forensic patients. There was one study prior to mine, but it was conducted in the UK, so mine was one of the first ones conducted in the United States using the cover in forensic patients. And his hypothesis was, and this has recurred in the literature subsequent to his theory about why these relationships between risk assessments that I saw here, is that all risk assessments, regardless of what the items on, are sort of capturing in one way, shape, or form antisociality of the people that we're evaluating, and that's why they're all pretty good, but they're all not perfect. And in a horse race, which Dr. Monahan doesn't think any of them should be subjected to it, they're all going to come out the same. And that's what the literature has shown pretty much, is that it doesn't really matter which risk assessment you use. If you're only looking at predicting outcome being defined as violent or violent recidivism, then it doesn't matter which one you use. Any of them would work just as well as the other one. And the cover shows that you could use the cover. For forensic hospitals, though, that's not what the most important thing is, right? The most important thing is to develop treatment plans, to treat the patients. So you want to understand more than what's just going to happen down the road. You want to understand what's going to happen while they're in your hospital, and you want to be able to intervene so that down the road they don't become violent. And that makes a difference if that's what you're wanting to do in terms of what you select. These are a bunch of graphs that just show that the cover is almost as good as any of these other instruments in if what you're looking at is predicting who's going to be violent. And so the top ones are the relationship between the cover scores and the violent behavior, and the bottom ones are the various instruments. So the previous one was the PCL. These are the different kinds of aggressions. So predatory aggression, obviously the PCL is going to do better than the cover, but the cover wasn't bad. So what this suggested was that the cover was okay as a screening instrument. Don't need to do much record review. If all you're interested in is identifying people who are much more likely to be violent in the relatively short term, then rather than doing a VRAG even or an HCR20, doing the cover on admission to understand or to at least identify and implement treatment programs for who's more likely to be aggressive is probably the best choice. If you can afford it, it's not the cheapest instrument in the world because it's a computer-driven instrument. So not unlike many computer-driven instruments, you pay by the administration, not not paying for the program, or at least that's how it used to be. I don't know if it still is or not. And this is a direct quote from John Monahan: to the extent that different risk assessment instruments have similar predictive accuracy, how would you choose among them? One way is on a cost-benefit grounds, if time is money, then use the one that takes the least amount of time. And so he was all for using the cover as a screening instrument. He's also one of the authors on the instrument, though, obviously. Did somebody say something? Is that a question or just a comment? Or talking to somebody else? I can't hear. Oh, because John's one of the authors. So now we're going to actually start to get into some of the programs that were implemented at the various hospitals. We're first going to talk about what was happening at Napa, because that's where all of this research was conducted. So I explained to you the big system and how all of the patients in the system are forensic, or the majority of them are, and all of the hospitals have problems. All of the data to date that I've talked about is come from all of the patients, from some of the patients at Napa. So the importance of identifying impulsive aggression is that you can understand what's going on in the interaction between patients and staff to try and intervene in that way. And one of the treatment programs that was implemented in Napa, based a lot on this data, was a dialectical behavioral treatment program, DBT, and so there are now 3 units at Napa State Hospital that are considered DBT units. 1 unit for the civil patients, where the entire unit is DBT, and then units on 2 other units at Napa State Hospital where parts of the unit are DBT patients, and the staff are all trained in the DBT approach, and it's used with all the patients that are in the DBT program. And that's primarily to target impulsive aggression. So that was one of the interventions that came out. We have a process. I imagine you probably don't, partially probably because your system isn't quite as large, but we have a very large forensic system. And so we have a process where if we don't think that we can provide treatment anymore to them, and that the best place for them to be for everybody's safety is prison, that we can transfer them to the prison system. It's called a 7301, and it's 7301 because that's the penal code in California for the transfer process. Generally speaking, you have to demonstrate that they have no major mental disorder, no Axis 1 disorder, that they are more likely to be antisocial personality disorder, and they've exhibited predatory aggression. And then they usually will accept the transfer. CDCR gets to decide whether they want the transfer or not, and they also get to decide when they don't want the person. So we've had patients that were transferred to the CDCR and then transferred back. There's another program that I can't actually remember when this slide was made, but it was quite some time ago, and this program has been in development for a number of years and just opened a month ago. It's a specialty unit to treat the most aggressive patients in the system. And so right now, one of the units has been opened. It's a 13-bed unit that is designed to treat the most aggressive patients in the hospital. It's based at Atascadero because Atascadero was a purpose-built forensic hospital, so it has more secure. It has a more secure design. The units, it's taken so long for a variety of reasons. One is that the units had to be completely redesigned. They're single-person units that the staff has the ability to lock them in their room, and it's not considered seclusion. and I'm sure that Dr. Warburton would have spoken a lot about that with the rules and regulations that go into seclusion. There are rules and regulations that go into being able to lock somebody in their room and have it not be considered seclusion. And the enhanced treatment unit that just opened up at Atascadero has that capability of being able to do that. Right now, the last I heard, which was Monday, is that there are 8 patients on that unit, and it has a capacity of 13. But 3 more units are being developed, 2 more at Atascadero and 1 at Patton State Hospital to be able to treat women. So, so could you say that a little bit louder? I couldn't hear it unless somebody else can. You're asking them to come to the microphone? Well, you know, that's a very good question. My expectation was that they were going to be more predatory, and Dr. Warburton probably could have told you this story if she was here, but I'll tell it for her. She stayed at Napa State Hospital because I strongly encouraged her to, because we were, and this was in 2005 or 2006, we're talking about opening a unit just for psychopaths, for people that scored really high on the PCL, and of course couldn't find a psychiatrist that wanted to work on it, and so I twisted her arm and she said yes. It was a logistic nightmare and didn't ever open, actually. So that didn't work out. I think that my expectation was that that's what this enhanced treatment program that is now open at Atascadero would be. As it turns out, that at least currently, the majority of the patients are people who have an unremitting psychotic disorder that leads to their aggressive behavior. And so they're repetitively violent because of their psychotic disorder that has not responded as well as others do to antipsychotic medication. But it's a small sample right now, so we don't know. You know, there's going to be 30 more beds, so not sure what will happen as the treatment continues. Sure.
We have another question.
Hi, I have a question. When it's pretty clear that the vast majority of the NGRI and the restoration to competency patients are male, sounds like about 80% in California, and that proportion here as well. Since we know there's a contribution from testosterone in aggression, territory defense, etc., I'm very curious if you could comment on why that is rarely, if ever, addressed or treated. It's almost as if it's a sacrosanct subject that we're not even to broach.
I don't have the answer to that question. So why are we not addressing the role of testosterone in violent behavior?
Yes, especially when it's so clearly related.
I don't have an answer to that question. I don't know if anybody in the audience has any speculations about why that might be.
I think it might be from projection of our own desires. I don't think anyone wants their hormones messed with, although females have their hormones messed with very, very often in lots of different ways. But I'm just thinking it's glaring that if we know that the vast majority are male and that testosterone is directly related, just like we know that dopamine is related to psychosis, why don't we treat that?
I don't really have an answer. I would guess some of the answer could potentially be the ethics of it, but I don't really know. It's never been discussed at any of the hospitals that I've been at.
I guess I'm pushing it a little bit because I've run into this several times, like with patients that have testosterone 2 standard deviations above the norm, but could not get that lowered to allow him to return to the community. I think it's a shame that it's not addressed and that they're often deprived of liberty that they could have if they weren't so tormented by that very primal contribution.
Okay, thanks. Let me back up on this one for a minute. Dr. Warburton would have spoken about this if she was here. You're raising your hand, so you must. One of the big characteristics, and I think we'll get to this later, but I'm certainly, we'll just skip over it when I get to it later, is that it's only 13 beds. Remember, we're in a system where the smallest unit, at least at Napa, is 33 beds, which everybody knows. And I imagine none of your units are that big, because everybody knows they shouldn't be that big. So it's only 13 units. They all have their own rooms. And so when we were thinking about opening this unit just for people that scored high on the PCL, I had interviewed a large number of the individuals that had scored high on the PCL, and they're usually very talkative and certainly like to be helpful when there isn't any problem for them to be helpful. And so I talked to several of them, and one of them told me, you know, the biggest draw that you would have to get us on your unit, he didn't say it quite like that, is to give us private rooms, because private rooms is a hot commodity at all of our hospitals because they're so big. And so having your own room, so 2 of the what we call discharge units now are all private rooms, and so it's a great motivator to try to step towards discharge, because you get to go on a unit that is beautifully remodeled and have your own private room. So that's one thing. So they all have their private rooms that they don't have to be locked in. There are various treatment programs being developed. So there's a cognitive rehabilitation program that's going to be implemented at the specialty unit, and they're all targeted towards dealing with the various precipitants to aggression. So there is going to be, and this is relating to what I was going to talk about, there's going to be medication algorithms. Dr. Warburton established a group of psychiatrists called the PRN team, and I forget, Psychopharmacology Resource Network. And everybody knows, obviously, PRN stands for as needed medication. And they will consult with the unit. They'll actually consult with anybody in the hospital, and now have established consultations across the world. Actually, they're consulting with people in Australia and New Zealand, in addition to other people in the United States. So there's lots of specialty programs within the specialty unit that will provide treatment dependent on the needs of the individual. All of the people that come onto the unit, it was a disability rights issue. So they have hearings, there's panels that make these determinations, there's intensive risk assessments that go into evaluating the individuals and documenting what their aggression was and what the reasons for the aggression were. There are appeals that can be made by the patient if they disagree with the interventions. I mean, it's a legal process that actually happens. So it's intensive treatment in a small unit with individual rooms. Don't have to be locked. Enhanced staffing, of course. I mean, it's sort of the ideal treatment program. Napa, and I know all of the hospitals are like this, the maximum number of treatment providers on a 45-bed unit, excluding nursing staff, is 2 full treatment teams, which is comprised of a psychiatrist, a psychologist, a social worker, and a rehab therapist, and then nursing staff, and depending on the level of acuity, the ratio of nursing staff varies, and rarely, because of staffing shortages, do they have those full complement of treatment providers. But at the specialty units, they're going to make sure. The other thing that we have happen at Napa, and not Napa, DSH, and I don't know if this happens in Texas, is that we have nursing shortages, and yeah, okay, I think it happens everywhere. Yeah, well, we have all of those shortages too. I think the one shortage we don't often have, although I think we do now, is psychology. I've heard that that is not the case in your system, that you do have psychology shortage. And so the problem with nursing shortages is that if a unit is under their staffing ratio, then nursing staff are mandated to work overtime and, quote, floated to units that are not necessarily their home unit. And that's a problem. They're usually doing that because of a high acuity patient, and so they're on what we call a one-to-one on the patient, and anybody that has worked in these systems knows that those people are most at risk of being assaulted because they're on a one-to-one with a patient who people are concerned primarily. Sometimes it's for suicidal behavior, but primarily it's for people that we're concerned are going to be violent, and so we're putting one particular staff who may not even be familiar with the patient in a situation where they have to keep an eye on that patient. So it's a big problem at all of the hospitals, is the nursing shortage, and that leads to dangerous situations, quite frankly, for some of the nursing staff. So, and it's, you know, it's not for lack of funds to be able to pay for the nursing staff. It's for lack of people being interested in working in this very hard situation. So it is, I'm sure you all have this kind of a scenario as well. Yeah. You mean the physical size? Well, it's certainly, obviously, for what's the word I'm looking for? It can't be taken into consideration for hiring purposes. You can't have criteria, you know, that staff have to be a certain size to be able to hire them. I don't know about in Texas. I imagine that it's different in Texas, but I actually don't know. But the majority, I think I'm accurate in saying the majority of our nursing staff are Filipino, and I don't know how well you know Filipino women, but they're usually very small. So it is somewhat of a problem, but you know, and they're wonderful nursing staff, and they, you know, truly do a good job, but it's that they're no match for people that are twice their size if somebody becomes violent. So it is a problem, but I don't think there's any sort of effort to hire big men. So that, I hate to say this, but I think it's not that they'll hire anybody, but I mean, there are obviously certain criteria for getting hired at these hospitals, but we have such severe staffing shortages that having enough people is important as well, not just the size of the people that we have. So, and I don't think that was ever taken into account for these specialty units that are going to be at Atascadero and Penn State Hospital. It was just having the right numbers of people. And a lot of the staffing ratios are based on the acuity of the patients. So, did I answer all your questions about specialty units? Any more questions about those units? There's only one right now. Well, actually, there are a couple of other ones that have been around for a long time. And they're various. I'll get to this at the end. There's various different kinds of units at the various different hospitals to treat various underlying problems that I'll get to that do help in managing violent behavior to some extent. And then there's the psychotic stuff, which is primarily trying to find the most appropriate antipsychotic medication. There's Clozaril studies that have gone on a lot at our hospitals. The treatment of choice for seriously violent patients that are, even if they're not psychotic, is Clozaril, but obviously definitely if they are. And so the majority of our patients actually have had a Clozaril trial at least, and may still be on Clozaril. And that's largely because of an effort of the PRN network to provide these consults and provide direction on the appropriate medication management of some of these patients. So these are some of the programs. We're going to start briefly with the one at Napa that happened, and then we're going to go on to talk about, in whatever time we have left, the other ones that are going to be occurring across the state. The one that happened at Napa, and I'm using past tense because it doesn't happen anymore, we had started, and by we I mean Dr. Warburton and I, had started an admission screening process for all of the incompetent to stand trial patients that had come into the hospital, because she believed that the long length of stay for those patients at Napa State Hospital was because they were all malingering. And then once they get to the unit, the staff don't really know what to do with them because they're faking illness, and so they don't really know where to go with them. So we decided to start screening everybody on admission, and one of the assessments that we did was an assessment to determine if they were feigning psychiatric symptoms on admission. We also evaluated competence, we evaluated their psychotic symptoms, and then further along, I was presenting some data on the cover at an Apple meeting, and when I was finished presenting, and I think Dr. Warburton was at that point now forensic chief at Napa State Hospital, turned and looked at me and said, "When were you going to tell me about this data?" And largely because of her efforts, what we started to do with all of the new admissions at Napa, not just the IST patients, is that we would add on the administration of the cover. And the program evolved over the years, but ultimately ended with writing a summary of the patient and sending it to the treatment team. And also, if we thought that somebody was going to be violent, then there were procedures in place that I'll talk about in a second or actually if we thought or they scored high on the risk assessment, there were procedures in place to what to do with that particular individual if that happened. We also, because there was a 20-week, the MacArthur study was 20 weeks, the cover was developed from the MacArthur study, we looked at acts of aggression 20 weeks post the administration of the cover, 20 weeks post-admission. I'm going to skip that. John Monahan, we just consulted with him, and the manual even says that you can adjust the score if you find reason to. So our staff did. They could adjust up or down. So if they thought it was an underestimate, they could say that he scored such and such, but we believe that their risk is higher. And these were some of the reasons that they adjusted up. So they had a history of assault. They were extremely psychotic and had exhibited aggression related to their psychotic symptoms, or they were just unreliable, oppositional, defiant, and so that doesn't bode well for treatment teams. We could adjust down if we thought that their responses were unreliable and they just were sort of responding randomly, and so they scored high for no good reason. Or if there was no history of assault and for some reason that we didn't know, because we don't know what the algorithm is for the cover, that they resulted in a high score, but we didn't really think that they were high. So those were the reasons for, or if they were calm. Initially, we communicated with the treatment teams, and so we would call the treatment team and tell them they're scoring high and to be on the lookout for that. Eventually, the hospital police officers, when the individuals scored high, were required to stay on the unit. The admissions suite at Napa's a huge campus that's on 300 acres behind, but the forensic units are behind a secure perimeter that has razor ribbon and a sally port with a controlled entrance and exit. So the hospital police escorted them anyway to the unit because they aren't allowed they weren't allowed to go. They can't walk themselves, obviously. But the hospital police were required to stay on the unit until the treatment teams, including the nursing staff, felt that they were okay and were comfortable being able to manage the patient themselves. And this is what we found. This was the relationship between the cover and the different kinds of aggression, physical contact, physical injury, and then total physical aggression, and they're not great. Remember I said that 0 is no relationship and 1 is perfect, and most of what we've seen is 0.5 or above. None of these even came close to 0.5 except for the clinical judgment, and that was the judgment of the evaluator that couldn't administer a cover. The evaluator wasn't able to administer a cover, and largely the evaluators aren't able to administer the cover if the person is so agitated or if they're refusing and oppositional or if they're so psychotic, and obviously those kinds of people you would estimate would be at higher risk of being aggressive. And so that's why that came out higher. So that isn't particularly good news. These data aren't particularly good news. This is a little bit better. This is a graph that I'm not going to go into a lot of detail, but not just one, but multiple people that work in risk assessment say that if you're using risk assessments properly, that when you do these kinds of studies, the relationship between the risk assessment and the acts of aggression is hopefully going to be close to 0 because you're using the risk assessment to intervene to mitigate their risk. And so the only reason you have high scores is because people that score high on risk assessments are the ones that end up being aggressive, and if you do something to mitigate, then that sort of relationship washes out. Does that make sense to you all? So if you use risk assessment properly, you shouldn't see any statistical relationship between the risk assessment and aggression. And that's sort of what happened. Initially, as we were establishing this program, we didn't have all of these things in place. And so initially the cover was more predictive. It still wasn't as good as some of the other instruments, but it was more predictive. And then as we implemented the procedures where we had to contact the treatment team and the nursing staff, we had the hospital police officer staying on the unit with the person. As we started doing those procedures, the relationship between the cover score and acts of aggression started to decline. And so I think the take-home message here is it actually doesn't really matter what risk assessment you use as long as there's procedures in place to mitigate the risk. So if you're just using risk assessment without putting it to use, then you're not really getting anywhere with what you're really wanting to do, which is to manage their risk in a way that mitigates it. So what have we learned? The cover's useful, clinical judgment helped, but the biggest thing is that there were protocols that were put in place to decrease the aggression so that that decreased the relationship between the risk assessment and subsequent aggression over time. I'm going to spend some time. I got a question at the break. Let me stroll across the stage to make sure that I have enough time to spend a little more time on this one. Not a lot more, but a little. This is the environment-centered approach. This is an assessment that looks actually at factors that are going on in the environment that could be intervened with, it's probably bad grammar, but anyway, to mitigate risk. So this is looking at all kinds of different things, and we used a model called PRISM, Promoting Risk Intervention by Situational Management. It was developed by Dr. Cook from Scotland, and he's worked with Dr. Scheme from UC Berkeley, Jennifer Scheme, so people may have heard her name because she's done a lot of forensic work. The two of them have worked together to try and implement this program at Napa State Hospital. It's the one that blew up last week, but I'm going to tell you sort of the ideal, and then I can tell you why it blew up. And I think there's some pretty good reasons why it blew up. It's a systematic process for evaluating a range of situational risk factors known to influence institutional violence in prisons and secure hospital settings. It's never been used in the United States. This would be the first time that it was ever used in the United States. It's been used in, I think, New Zealand or Australia, and in the UK and some other places around the world, but never in the United States. There are various domains. One is the history of violence, physical security, organizational features, and I'll give you a definition of what that means, staff features, and case management features. History of violence is just exactly what it sounds like, whether there's been any violence in the hospital, what the diversity is, whether it's changed over time, gotten better, gotten worse, changes in complaints. Those are the factors that you evaluate. The PRISM model is a structured risk assessment that has 22 items on it. So it's a structured professional judgment tool in the same way that the HCR20 is. Physical security is everything that you would imagine, you know, the physical environment, and of course, some of it is looking at whether it was purpose-built, and I've already told you that, you know, 3 of our hospitals are not. And what the security measures, you've heard that our security has been upgraded since we had that tragic incident. Organizational features, so what the organization thinks about whether or not violence is a priority, what the sort of ethos is, are there policies and procedures that are in place to manage aggression? So the PRISM model is evaluating that. What the staff features are, so what their training and competencies are. Are they administering risk assessments? Is there somebody identified to do that risk assessment? How are those risk assessments communicated? How involved is the nursing staff in the risk assessment? Because, you know, the nursing staff are the people that spend the most time with the patients. They're on the unit 24/7. They're required to be there. There was, just as a little bit of an aside, I don't know how it's worked in Texas, but in California, the majority of what we call the ancillary staff were allowed to work remotely. And the ancillary staff are psychiatrists, psychologists, social workers, rehab therapists. Obviously, in a hospital, nursing staff are not allowed to work remotely. They have to physically be present. And so in one of these PRISM evaluations, we were interviewing the nursing staff and the ancillary staff. And one of the nursing staff said that, you know, they felt like it wasn't really fair that the ancillary staff got to stay home and work remotely, and the nursing staff always had to be there. And so they communicated that to the ancillary staff. And so the ancillary staff didn't start coming to work, but they did start doing nicer things to the nursing staff to acknowledge that there was this discrepancy, which did help in some of the discord and disconnect for that. We were all back to work full-time for about 2 weeks until the Delta variant hit, and then everything went remote again. I don't know if that happened here or not. Another very important factor is the staff's interaction with the patients, and we saw that with the impulsive aggression. If there's a way to deny patients something without irritating them too much, and a way that probably is more likely to get them angry at you. And so that was part of the PRISM model as well. And then just whether or not risk assessments are done and whether or not they're communicated, which is probably more important. It doesn't really do much good to have a psychologist doing the HCR20 if the only person that knows about the psychologist doing the HCR20 is the psychologist and the psychologist supervisor. The treatment team, the nursing staff need to know what came out of the risk assessment, and it needs to be incorporated into the treatment plan that's communicated to everybody. And that has been a problem at Napa, where the nursing staff have routinely said, we don't know anything about these risk assessments. We know they're done, but we don't get the results of them. And that's a problem. That needs to be changed. This was just the procedure. We interviewed both staff and patients, so we picked 5 staff on every unit. We made sure that 3 of them were nursing and 2 of them were either social work, rehab, or psychology, with a focus on psychology because a lot of it was on risk assessment, so we really wanted to make sure we had at least 1 psychologist and then either a social worker or rehab therapist. And we definitely wanted, because nurses are boots on the ground, we definitely wanted the nursing staff's perspective on this. And then we asked the patients. We got their perspective on it, and sometimes it was the same as the staff and sometimes it wasn't. They were scored. We had consensus ratings. We had a risk assessment that resulted. We had planned a randomized controlled clinical trial where we matched 14 units, so 7 matched pairs on levels of violence and their risk scores, and we were going to do this RCT where we did interventions on one of the pairs and just business as usual on the other. That didn't go very well. And what do you think was the reason? Does anybody have any guesses why this blew up last week? And it blew up because there was mutiny on the units that were the intervention units that didn't want to do it. Was the reason. Does anybody have any guesses as to why? Because we've implemented a lot of new programs across the state, and I'll get to more of them. Any guesses? It was required for staff, yeah. Did it require more staff? No. Maybe. I think one of the biggest problems, and we don't really know, I mean, this is just a guess on my part. There's been lots of programs that have been implemented at various hospitals across the system. The DBT was implemented. Apparently, one of the people on the PRISM team was in the DBT implementation project, and he said that it was challenging and that there was some resistance, but that ultimately people got on board, and very intensive training. I don't know if you all have DBT programs in your system, but the training is pretty intensive, and it's an intervention where you have to respond certain ways to the patients on the unit, and you have to be consistent, but it's patient focused, right? It's really focused on decreasing the impulsivity of the patient, and it's giving the staff different methods for decreasing the impulsivity of the patient. This was not patient-focused. This was not at all patient-focused. This was focused on what the problems are on the unit and how to fix those problems. And so the resistance was that people's perception, and this wasn't actually true, but I understand the perception was, you're telling us that we're doing something wrong, and we're doing the best we can do, so leave us alone. We're doing the best we can do in the situation that we have and with the skills that we've been given. So we don't want you fancy people coming in and telling us what we're doing wrong and trying to make us change that. And I think that was what the hurdle is going to be to overcome. And we haven't given up yet. We've reduced from 7 matches down to 4 and potentially down to just 1, just as a demonstration to see if it works. But there's ongoing negotiations about whether or not this is going to work. And I totally understand what the resistance is, because we're not focused on the patients and we're not talking about what's wrong with the patients. And quite frankly, it isn't the physical characteristics, which are a problem at Knapp State Hospital. It's an old facility and it has some problems. But we're not really talking about the physical characteristics or the security characteristics. We're talking about the staffing characteristics and how to change that. We were also talking about, example, for the IST units, they don't do the cover screening, got eliminated in 2017, unfortunately, and so that's no longer being done. It was supposed to be replaced by the nursing staff administering a Brosset. Has anybody heard of the Brosset? It's very, very sort of straightforward. You're evaluating the symptoms that you observe in the patient. But there was no requirement for documenting that the Brosset was administered. And so if there is no requirement for documenting that something is done, what do you think the chances are that it's going to be done consistently? And so it eventually fell by the wayside on a lot of units because, you know, there were so many other pressures. So there was a sort of marginal procedure for that to replace the cover, but it hasn't been particularly effective. So that was going to be one of the interventions for the IST units, was to reinstate some kind of evaluation of risk as soon as the patient hit the door. Because IST patients, because they're unstable often and come from jails, are sometimes some of the more violent people. But it was also going to be looking at, you know, doing different things with the staff and the characteristics of the treatment providers. And I think that was threatening to people that were working hard and, you know, doing the best that they could do. So still, jury's still out on what's going to happen with that. So it's not really until I'm sure that this is going to work out. Probably isn't worth talking about what some of the interventions were, but I have talked a little bit about it. And one of them, very importantly, would have been changing how risk is communicated and making sure that everybody on the treatment team knows that a risk assessment has been done and what the results of the risk assessment are and what that means for how you intervene with the patient. And that actually is what most of it was focused on, but I think the perception was that we were telling them what they were doing wrong, and so that was part of the problem. So we're working on it. So what other things have happened at DSH in the last few minutes that we have? I think I've mentioned this. I've been very lucky that for the past 20 years, I've worked in this system that really values data and really wants to make decisions based on data. And a lot of that has become apparent with the IST problem that we've had, but it also, as you see some of the programs, the changes in some of the programs have been based on the data that has come out of some of the research that we've done on what to do about some of these problems. And lots of what I've talked about, in fact, exclusively what I've talked about up until right now is just from Knapp State Hospital. But there's been other stuff statewide that I'm going to tell you about now. This is from one of my colleagues at DSH, and he looked at the numbers of acts of aggression in our entire population of over 6,000 people. And what he found, the green is all of the patients that have not exhibited any acts of aggression. And so obviously, and that's probably true here, the majority of the patients aren't violent. It's the small number that are, and the even smaller number that are repetitively violent, that are the problems in the hospital, and the people that this research anyway is focused on trying to manage. So a not insignificant number have had at least one act of aggression, but a very small percentage, and that's what the yellow is, one act of aggression. A very small percentage have had more than 10 acts of aggression in the hospitals. 1% of the patients accounted for about 30% of all of the assaults, and a little over 1%, 1.5%, had 10 or more acts per year and accounted for 37% of all assaults. So it's not everybody. You know, the majority of the patients don't exhibit violent behavior. So somebody looked at that to try and understand who these chronic aggressors are. Who are these 1.5% of people that exhibit the most aggression? And what he found by looking at people that were exhibiting chronic aggression and exhibiting severe injury and matching them with people that didn't in various features of the patients, that the people that were exhibiting chronic aggression were the people that had some kind of cognitive deficit, either intellectual disability, traumatic brain injury, or dementia, some kind of cognitive problem. And so he has been sort of the source and the force behind developing cognitive rehabilitation programs throughout the state. And so currently at Napa State Hospital, there is a cognitive rehabilitation program that he's developed with assistance from Dr. Philip Harvey from, I think, Florida, who's done a lot of work on cognitive rehabilitation with psychiatric patients. And so he's right now implementing that program and is collecting data to see how effective that program is at DSH Napa. And it has a variety of different interventions that I don't have all of the information about what he's doing. And it got sort of derailed because of COVID as well, because a lot of the interventions were off unit and the patients weren't allowed to go off unit during the worst parts of COVID. He also wanted to look at who caused the most injury, and this shouldn't be surprising to you if you look at what he found based on everything that we've already talked about today, and who causes the most severe injury are the individuals with severe personality disorders. And that's a DSM diagnosis, so we're primarily talking about antisocial personality disorder and borderline personality disorder, and that's what the DBT was directed towards. So those two diagnoses, I think DBT was initially developed primarily for people with a diagnosis of borderline personality disorder. It has been extended to working with people with antisocial personality disorder, and so both diagnoses are allowable in our DBT programs at Napa State Hospital. Right now, all long-term patients are required to be evaluated on a risk assessment. And the ones that are being used currently in DSH are the HCR20, which is being used in the forensic patients at Napa, and I think a couple of the other hospitals are using the HCR20. The START, which is the short-term assessment of risk and treatability, which is another structured professional judgment instrument. The PCLR is also being used at some of the facilities, and then some of the facilities are using some other screening instruments. So the VRISC-10, for example, is being used at Atascadero, I believe. But every hospital is using something for their long-term patients. At DSH Napa State Hospital, the START is used on the civil psychiatric patients, and the HCR20, which is more forensically based, is used on the forensic patients. There has been a program to develop CBT for psychosis at a couple of the facilities. One of them, unfortunately, was at one of the DSH facilities in the CDCR, and the CDCR took over that facility, so that one stopped. But there are other CBT for psychosis programs in the state hospital system. They had planned on doing a controlled trial, but that has not yet taken off. But they really want to look at the data and study it to see if it's helpful in reducing aggression. I've talked about the PRN and medication management. The PRN team will consult with anybody that is interested in getting help with medication and how to manage patients' psychosis and aggressive behavior. There have been some de-escalation trainings that have been considered. There was one that was considered and sort of previewed by the administrative staff right before COVID. I think it was February 2020. And so nothing's really happened with that. The PRISM people brought in some people from Missouri to do their de-escalation training. So we have actually providers at Napa State Hospital that are trained in de-escalation training to train these units to do de-escalation training, to do de-escalation with the patients. So if our PRISM program gets off the ground, we'll hopefully be implementing that, and we'll have some data eventually that we can provide feedback about that. Trauma-informed care has also been implemented, and data is being collected on how that's working. There's 2 places. Napa State Hospital is one of the places that is implementing trauma-informed care in a structured way, and Metropolitan State Hospital is another one, I believe, that's implementing trauma-informed care and collecting data about the effectiveness of it. I've already talked about the DBT. I've talked about the cognitive rehabilitation and the environmental changes. Beyond what I've already told you about, we obviously eliminated one not particularly successful alarm system with another one, and that actually has gone statewide. So all of the hospitals now have the GPS alarm system that tracks them anywhere in the hospital, and we all get our own personalized GPS monitors, and so the hospital police actually know who it is whose alarm went off, and they can watch them walking, watch them wherever they're going, so they know where they are, and they also know if people are coming to help them, because they can see on a screen little red dots of people moving towards the person that's in trouble. So it's a pretty sophisticated system, and it works outside, which was one of the issues associated with the event. A psychologist from Texas, Dr. Bob Morgan, has worked with DSH. I don't know if any of you know him or his work. And he's done some evaluating and looked at what some of the criminogenic factors are in some of our people in the hospitals, because all of the forensic patients have criminal involvement, obviously. And he's developing an intervention program to target criminogenic risk factors, and so that actually is going to be one of the pilot programs in the specialty unit at Atascadero, is piloting a treatment program to address criminogenic risk. And I've talked about the enhanced treatment program, so the criminogenic risk program is going to be one of the programs within the ETP. And we've already talked about that. It's the various levels of care, the highest level of care. And the first patient was admitted on September 14th, 2021. It was supposed to open in March of 2018. So here we are, 3.5 years later, but it has finally opened, and so hopefully we'll be collecting data. And that is the important part about DSH, is that all of these decisions are made based on data. And so that, I think, is one of the things that Dr. Warburton definitely wanted to communicate, is how important it is to get money, quite frankly. And that's her skill, is being able to argue with the legislature that these things are important and they will help improve the quality of the treatment and help improve the lives of the people that are providing the treatment. And so she's been pretty successful at getting the legislature and the governor to award a significant amount of money to develop some of these programs. The ETP was very controversial, and it took a really long time to get that through, but she was able to get it through, and it was based on data that she was able to provide to them about some of what we've talked about here. I'm not sure if that's a question. And I've talked about this, the non-pharmacological treatment. So you've essentially, the last thing, there is a substance use treatment. Is substance use a problem for your patients? Is methamphetamine as big a problem in Texas? Yeah. I saw a study recently that the farther east you go, the less of a problem methamphetamine is. California has the worst problem. Colorado has a problem, but it's less. But it sounds like Texas is closer to Mexico. And a study that I read recently, I used to think that all the methamphetamine came from Central California, but most of it is coming from Mexico now. So I wonder if that's related to why you guys have a problem. We have I mean, everybody recognizes that substance use is a problem. There is a specialty unit at Napa that has been around for several years now, where people that have substance use problems go to that unit, and they have specialized programs for those individuals. Not surprisingly, the majority of the people on that unit have a diagnosis of antisocial personality disorder. So it does have some problems on that unit, but it is trying, the unit is trying to do what it can to intervene with a significant substance problem that majority of our patients have. Some studies have shown that 80% of our patients have comorbid substance use diagnosis. The data that I'm collecting from another program shows that 87% of them have a comorbid substance use diagnosis. So it's a significant problem in California. One of the things they do is routine random drug screens. For a very long time, Napa was not allowed to do random drug screens. It had to be for cause. That's not true anymore, but it was all patient rights sort of issues. But I think that now they're allowed to do them randomly. And this was what we wanted to end with, is the challenge, which is to balance treatment and safety, both not just for the staff, but for the patients. We have, 20% of our patients, of our forensic patients, being high on the PCL means that the targets are likely to be the most vulnerable patients that we have in the hospital, which are the patients that are very psychotic and aren't conning and manipulative and don't understand that could be a problem. So trying to figure out how to get this all done in an enormous system with all kinds of different patients has been a challenge. And that's why all of these specialty programs have come up, is because we're sort of trying to address it as best we can in various ways with various different kinds of patients. But I think that the thing I suppose I want to leave you with is how important it is to understand what's going on in your hospital, how important it is to understand the patients that you're treating and the diversity of the patients that you're treating, and to do that, assessing them is very important. Dr. Hughes wanted me to briefly discuss how that worked at Knapp State Hospital. In the entire system, we have a contract now with Dr. Kevin Douglas and Dr. Sarah Demaray, both of whom come in on a regular basis and train on the HCR20 and the START, because those are the two primary instruments that are used. At Napa State Hospital, before that happened, the chief of psychology decided on his own that he wanted all of his staff to do the HCR20, on the forensic ones anyway. And so he developed a training program that involved providing case vignettes for all of the staff, all of the psychologists at Napa, and Napa has a pretty large psychology staff, and having them practice scoring the HCR20 until they reached a certain criterion where they did it right, and then they were free to do it on their own, but they had to keep getting recertified every year. So it was a challenge to implement that program, and it took a year or two for him to get it sort of moving smoothly. In that year or two, there was a contract developed with the HCR20 people, and so they came in and supplemented that. So it isn't easy, I get it, it's not easy to do some of these things, but it is really important to managing the risk for both your patients and the vulnerable patients in particular, but also for the staff who are at risk from a very small number of people, but it's still, they're at risk of being aggressed against. And that was it. So yeah, questions? It's a very simple instrument. Well, I don't know that it flopped. I think that if there's no accountability, then nothing's gonna work. So there has to be a mechanism for ensuring that it gets done and that it's communicated. Essentially. It probably isn't really that they just didn't want to do it. It's that there's so many other things you're doing when a patient comes to a unit and is being newly admitted that they were busy doing other things, and this was just one more thing, and they didn't have to put it anywhere. So having procedures in place with accountability. So we, in the admission suite, when we did the cover and the person scored high or they were agitated and aggressive, we had procedures that were in place that we had to do, and we were held accountable for them. So if we failed to communicate when one of the patients scored high on a risk assessment, then we were in hot water with the administration. So, yeah.
I'm also working on that same project that he's working on. What types of inter-rater reliability measures did you guys use on completing those measures appropriately?
On what?
What type of inter-rater reliability measures did you guys use to assure that the measures were completed appropriately?
For the Brosset?
Across the board, but yes.
So for my research, we had formal training and then inter-rater reliability checks throughout. For the HCR20 and the START, they have to be recertified every year and do a case example and do well enough on it. For the cover, in discussions with John Monahan, because it's so structured, he didn't think there needed to be inter-rater reliability because it's a structured assessment where you read the question and they respond. So So you have to know enough to know when the person's lying, and sometimes you know that because you have additional information. For the Brosset, the high-level nursing person worked cooperatively with the chief of psychology because it was replacing the cover, which was something that the psychology people did, to train them on the Brosset. I don't know if they established inter-rater reliability on the Brosset, though. So, but I think you should. For all of the instruments that require clinical judgment, you should make sure that people that are looking at the same thing are scoring it the same way.
Okay. Were the direct care staff completing it, or was it the nursing staff?
It was the nursing staff was supposed to complete it on admission. It was the admission nursing staff that was supposed to complete it. If the person scored at above level, a certain level, and I don't remember what that level was, then the psychologist then was supposed to administer the Brosset daily. The Brosset is only good for 24 hours. It's a pretty sort of face valid instrument where, you know, it's evaluating things like hostility and agitated behavior. So one would hope that inter-rater reliability, at least on the higher levels, would be pretty good. And hopefully on the lower levels too, because they're either exhibiting these things or they're not. But then the psychologist had to administer it on a daily basis until it dropped below a certain level. And that was really the only procedure. There wasn't anything else in terms of interventions or, you know, what should happen if they score high, other than that the psychologist just kept reevaluating them.
Okay, so there weren't any preventative measures put in place?
No.
Okay. That was
Nothing
fine.
other than what the standard is for what nursing staff have with an agitated patient.
Do you,
Yeah. Yes, absolutely. The Brosset has been very well researched. Yeah.
one final question. Do you have any recommendations on what type of preventative measures should be put in place for people who score high?
That's a loaded question. You know, I think one of the things that hospitals, and I think that that's why de-escalation training is so incredibly important. In reading, and I've read thousands of special incident reports at this point, and in reading the incident reports, it feels to me like the nursing staff have two things in their arsenal that they use with patients that are violent, and those two things are offering a PRN and offering a quiet room. So medication and seclusion, and they don't really have much more than that. And so that is why de-escalation training is so important, I think, and providing other alternatives for the nursing staff, who are the people that are on the unit. And so, of course, I'm sure it's true here. Nursing staff are the people that are assaulted the most because they're the people that are on the unit 24 hours a day, 7 days a week. They have to be. The psychiatrists and psychologists and social workers and rehab therapists can leave. And rehab therapists actually, and I don't know if your hospital has something similar, but rehab therapists are often there at much different times because they do all kinds of activities with the patients. But it's a very good question. What procedures can be in place besides just the standard, okay, you can go to a quiet room and you can have some medicine. What else can they do? What can they be trained to do? I think one thing is, and the Brosset to some extent helps with this, but understanding why the person's agitated to intervene. Any other questions? Well, I'll ask a question before I answer that question. And so my question is, what is the purpose of the risk assessment. I suppose what I would say is to do something on admission to ensure safety for patients and staff for a patient that you don't know that well. And so I would pick one of the free ones, which it sounds like you all are talking about. The BROSIT is free, the DASA is free, the VRISC 10 is free. You still need training on it, but they're free. But then I probably, for treatment, and I don't think this applies to the IST patients, and I know you have a fair number of IST patients. For the long-term patients, I would pick the HCR20. Any of the short-term risk assessments are not really going to provide you with much information on how to mitigate long-term risk, which really is the issue with long-term patients. I mean, it's what we in California, at least, with our NGI patients, we're not allowed to release them until they're no longer a substantial risk of danger to the community. And if, by the way, that means that they never are no longer a substantial risk to the community, then they have to stay with us. So sometimes we have a review panel procedure at Knapp State Hospital where we panel determines whether or not the person is ready to be released into the community, and if they're not, what kinds of things would get them closer to release. And sometimes we get referrals from treatment teams where they say, you know, the patient isn't going to get any better, and so why would we keep him here? And my response is always, that's not the criteria, is that we can't do anymore. The criteria is that the person is no longer a substantial risk of danger to the community. And so if they are still a risk to the community, even if they're not going to get any better, then it's our responsibility to keep them and keep trying to get them better. And maybe something, you know, if their psychotic symptoms aren't controlled adequately by medication, then maybe at some point a new medication will be developed that will control it, that will allow them to be released. But so that would be my answer, is I would do something right away to keep people safe and have a procedure in place. So not just do the assessment, but if the person seems to be a higher risk, then have some kind of procedure in place to keep people safe. But for longer term patients, to do more of the structured professional judgment tools that would allow you to include the dynamic factors, because those are the ones that lead to treatment interventions, suggestions. So, you know, if they're still psychotic, then that shows up on the C of the HCR20 and definitely shows up on some of the items on the START, which is an SPJ tool as well. It's longer, it takes longer. Some people think it's better because it takes strengths into account. I'm an old psychologist who has been doing this for so long that it's hard for me to switch from risks to strengths, so it sort of didn't compute all that well with me, but it's a highly regarded instrument, and that can be a benefit, and it's used at Napa for the civil patients. So if you could do two, that would be my suggestion. And outside of training, which is going to be a bear to overcome, at least the first one is free. You don't have to pay. The HCR20 isn't remotely free. So it's actually very expensive, especially if you want to have the ongoing training. If you don't want to have the ongoing training, I think you can get a license to have it accessible for everybody in the hospital that is trained to use it. And I don't know how much any of that costs. Dr. Warburton would have known all of that. So, well, thank you all. You've been great.